So may I now start the next session? May I request Dr. Lakshmi Narayan to start with his presentation, and may I request all the speakers to stick to their time in the interest that everybody else gets an opportunity to showcase with everybody's minds fresh. Please start.
Good morning, everyone. Myself, Dr. Lakshmi Narayan from Andhra Pradesh. Today, I am going to discuss about malunited tibia gradually corrected with osteotomy and laser fixation. So, deformity is change in its normal alignment in regards to one axis or one plane, or change in its orientation also. Either it changes its alignment in coronal plane or sagittal plane or axial plane. Anything, varus, valgus, procurvatum, recurvatum, translation, rotation, everything is deformity, even the shortening also. So we have to be thorough with the normal values in coronal plane, sagittal plane with mechanical axis, forming angles with joint orientation lines. In sagittal plane also, the anatomical axis, we have to be strictly thorough with all these normal angles. Then only we will know how much it is malaligned from the normal. So we have to know some nomenclature coming in deformity corrections. Cora, it is the center of rotation of angulation. It is the point where the proximal axis and distal axis meet at the deformity. And ACA is axis of correction of angulation. This is the axis where we keep the hinges and motors for the correction of deformity. So coming to rule of thumb in deformity corrections, if we hold a deformity with the thumbs on the convex side and index fingers on the concave side, it will correct properly. So in these four positions, at least we have to maintain olive wires or shange pins so that the deformity is held well. So some hinges we have to know. Convex hinge on the concave side, it is an opening hinge. If we keep the hinge little away from the convex side, it will open and lengthen at the same time. And if we keep the hinge on the concave side, it is the closing hinge. And translation hinge, rotation hinge, we have to be thorough with the all hinges. According to the case, we have to use the appropriate hinges. And three rules of osteotomy are also there. Coming to rule 1, if we keep the hinge and do the osteotomy also at the cora level, it will not produce any translation, it will just correct the deformity. It is the rule 1. It is the mostly followed rule. And the rule 2 is an excuse where we can't do the osteotomy at the cora level, but we can keep the hinge at the cora level, but we do the osteotomy little above or below the cora level. Juxtaarticular deformities where we cannot do the osteotomy closer to the joint, we follow usually this rule. Rule number 3 is both hinge and osteotomy are done away from the cora. This will cause a lot of translation and crooked bones. Most of the times, unless it is very necessary, we don't follow this rule. Coming to case examples, I will show some basic cases. 55-year-old male, proximal tibia fracture, neglected, took native treatment, ended up with varus malalignment and knee pain. This was his X-ray. It's varus malaligned and slight depression of lateral condyle is also there. So pre-operative planning is must for all the deformities. There is no role in on-table planning in deformities. It's completely pre-operative planning. We have to plan the axes. In a lot of apps are there, like I use Bone Ninja. So proximal mechanical tibial angle is 69 degrees. So we have to correct it to normal, 87 to 92 degrees. So around 20 degrees of varus deformity is there. So I followed rule number 1 here. This is little below the articular cartilage. So I kept the hinges at the cora level and did the osteotomy also at the cora level. So I followed the rule number 1. So I distracted on the medial side. So it corrected into good valgus alignment. So you can see post-correction. Preoperatively it is medial angle is 69 and post-operatively 92 degrees. Good valgus correction. I'm not that expert as Dr. Milind, where he does biplanar osteotomy, one transverse and one vertical osteotomy also to lift the articular cartilage. But after listening to his talk yesterday, I have to try those also to lift the cartilage also in these type of malaligned cases. So this is his alignment post-operatively. You can see the left limb now looks deformed. This is recovery. Coming to case 2, 43 years male. History of RTA 10 years back, he took native treatment, had been walking with a deformed leg, suffering from severe knee pain since 2 years. You can see this left leg is varus malaligned. This is X-ray. Proximal third tibia malaligned with the varus. with the medial compartment osteoarthritis is also there. This is his walking. You can see limp and mild lateral thrust is also there. This is the planning, mechanical axis is medially deviated. All the angles we have to do, cora, deformity, magnitude of the deformity, and you can plan the osteotomy also. Where to do osteotomy better, where can keep the hinges, everything we can plan in the app. And you can reproduce it on table. So here I followed the rule number 2, skin condition was not good at the cora level, but I kept the hinge at the cora level and did osteotomy little above, so it produced a little translation, but it is acceptable. Good correction was achieved. This is pre-op and post-op. This is working. All the limp and stress was relieved on the knee. Is working comfortably. Pain was also relieved. 35 years male, comminuted distal third tibia, took native treatment, neglected, present in 6 months with malunited tibia in valgus and procurvatum deformity. You can see large comminuted fracture. It is radiologically not solid union, but it is not moving. It is in valgus and procurvatum. So some translation is also there. So I followed rule 2 here in reverse manner. There is already translation, so that we can use translation rule 2, the hinge above the cora, so that it will produce the translation for correction of this deformity. Dr. Prasad sir will tell this as rule number 4. We use the hinge in reverse manner, rule 2. So I kept the hinge little above. This is oblique plane deformity. Hinges are also kept in oblique plane. It's corrected with, you can see the in first image valgus is corrected, and second image procurvatum is also corrected. You can see this is the result. This is working, is comfortable. Little limp is there. It is the initial follow-up. So this is one more interesting case. 24 years young male had childhood electric shock injury in the farm field, electric pump injury. Unfortunately, in this incident, his brother got severely injured. His leg got amputated also. Coming to this patient, anterior part of the right lower thigh, knee, upper leg, everything was severely injured. Underwent X-fix, multiple debridements, multiple transfusions, skin graftings, everything in the childhood. No quadriceps, no patella, or no anterior subcutaneous tissue. Only skin grafting and bone was there anteriorly. Complete growth arrest of the anterior knee. Posterior growth was progress. At the end of the growth, knee fused in gross recurvatum and 3 centimeters shortening. Not but not the least, he is seropositive for hepatitis B also. In seropositive cases, doing Ilizarov is very risky for the surgeon and the assistant also on the table. We have to be careful. So this was the situation after his complete growth arrest. Knee was completely fused in gross recurvatum. His foot was looking sky. So this is how he walks. To bring the foot onto the floor, he extends the right hip, he extends the spine, he flexes the left hip, he flexes the left knee. All the gait mechanics were abnormal. So he came with severe left knee pain in the adolescence at the age of 24 or 26 years. So he wanted to correct the deformity now. If nobody is willing to take this case, because high chance for, if it is not done properly, high chance for limb getting amputated. So we planned thoroughly as the deformity. We prepared the frame also preoperatively. He got around 73 degrees of recurvatum. We need to bring the leg down onto the floor. Please. You can see the posterior hinges, anterior, you can see the posterior hinges and anterior distractor. Frame check before night. This is on table. Anteriorly there was no place to open. I opened it medially and laterally. So did osteotomy very slowly. No skin breach, no posterior breach. So did osteotomy for around 20 to 25 minutes. You can see immediate 2 weeks post-op, site was opening up. This was during the correction. Patient was an engineering student. He used to send me all the calculations, how much is remaining, how much to distract, everything. Within 2.5 months, almost corrected. This is after 2 months. His foot was brought onto the floor. This is within 10 months, it got consolidated well. We kept little short and little flexed for ground clearance as it is a fusion knee. This was before and this was after. You can see he's walking. All the stress on all the other joints, hip, everything was relieved. Take home message, just 10 seconds. Proper clinical and radiological evaluation and planning needed before surgery. Take whatever time needed before surgery itself, plan, take opinion from colleagues, seniors. Pre-made frame will give better results and decrease the operation theatre time in deformities. No decisions on the on table. You should just do the case within 1 hour on table. No more thinking on the table. Everything we have to plan pre-operatively. Proper hinge and motor placement is needed. Post-operative period, close follow-up needed. I thank my guru, Dr. Vasudevan from Palakkad, for teaching me basics in Elizarov and deformity correction principles. Thank you, sir.
Congratulations. May I call the next speaker, Prashant Upadhyay, for his talk on TBI deformity correction. It's a fabulous case you have done. May I have a request for all the speakers, please? There's a rule about presentations, if you allow me to say so. Show, don't tell. We are not presenting at PG level here. Please do not start by enumerating with bullet points. Everybody is an expert in Elizarov. Make it easy for everyone to get your message. Go ahead, please. Your time begins now.
Yeah, good morning, everyone. So this topic is a very basic topic, a TBI deformity correction. I think almost all the points have been told by Lakshmi. And we already know what is the mechanical axis, anatomical axis, all the angles we know of. So I'll skip this. Just basic, I'll say if whatever deformity is there, what we need to do is first, we have to go for an angle analysis. Step one would be to make the proximal axis, to make the distal axis. Then wherever they are meeting, that is the cora or the apex of the deformity. We'll check for the magnitude of the deformity. We'll make the bone cut. We'll make the hinge and we'll correct the deformity. So if the apex of the deformity and the hinges are at the same level, this is osteotomy rule number 1, already discussed. Again, angle analysis, proximal axis, distal axis, magnitude, bone cut, the hinges, osteotomy rule number 2, and the correction of the deformity. Similarly, we make the proximal axis, distal axis. If they are meeting outside, then we draw another line. So there are two levels, the deformity is at two levels. So we make the bone cut at 2 different levels and the deformity gets corrected. Same way we can plan for the sagittal axis. Now this patient had a deformity in the proximal part, infected non-union with implant in situ with a bad skin condition. Now the hinges and the apparatus, they will take the shape of the deformity. So the proximal unit is applied as reference to the knee, the distal block is applied in reference to the ankle, and the hinges and the motor unit, they take the shape of the deformity. Now, as you open up the motor unit on the medial side, the rings will gradually become parallel to each other, and the deformity over the period of time will correct. Also, with distraction, the skin condition will become a little better as we are distracting the muscles also. Now, this was a single plane deformity. Now, what if the deformity is in both the planes? Let's say there is a anteromedial deformity. So it's an oblique plane deformity. Now, to plan for an oblique plane deformity, the important part is we see the vector laws. Let's say there is an anterior deformity and a lateral deformity shown on X and Y graph. Then the meeting point will be the plane of the deformity. So application of hinges would be perpendicular to this plane. So let's say if we are showing that there is an anterolateral deformity in an oblique plane, so the plane of the deformity would be somewhere in the anterolateral side, and a perpendicular to it, the hinge placement would be there. So in oblique plane deformity, the important thing is the placement of the hinge. And if making a triangle onto the other side, the motor unit would be somewhat around here. So this patient is having a medial deformity. So the apex of the deformity would be somewhat in the posteromedial side. And when you apply a fixator, there is a posteromedial deformity. So when you apply a fixator, you take the proximal ring reference to the knee, the distal ring reference to the ankle, and the hinge placement would be somewhat like that. When you rotate the leg, there will be a point in which the deformity would be maximum. So in that particular position, the hinge should be collinear and should be at the apex of the deformity, 1. Second thing would be if you rotate the leg, there will be a point where the deformity will be gone. So that in that condition, the hinges would be at the same level. And the deformity the Elizarov frame will take the shape of the deformity in AP as well as in lateral side. And with time, as you open up, the AP will get correct along with the lateral. So there will be opening up in AP, The correction of the deformity will take place in AP. Also, it will take place in the lateral side. With time, it shows correction. So what is important in deformity planning or deformity correction is planning. So if we fail to plan, is a plan to fail. Okay, thank you.
Great, that's an excellent demonstration. Thank you so much for sticking to time. I hope you all take it in the right spirit. Please, Dr. Subramaniam Gandhi, I apologize if I seem a little too harsh, but many of the concepts we've gone through in the workshops. So the theory part, we can keep it brief, and everybody will be very interested in seeing how well you solved the case, just like Dr. Prashant Upadhyay did.
Good morning, everyone. I'd like to thank the organizing team for giving me this opportunity. I'm Dr. Subramaniam Gandhi from Chennai. My topic would be the success of the surgery depends on a proper preoperative planning. So as orthopedic surgeons, we all know the treatment of skeletal deformity is the heart of our specialty. So this book was the initial book which was written in the year 1741. The goal of this book was to teach the different methods of preventing and correcting deformities in children. So since then, since Andre is writing 260 years ago, have we made a little progress? Only little progress has been made in the understanding, analyzing, quantifying, and knowing the type of deformities. So most of the orthopedic surgeons, what we do, we take a wedge here or there by eyeball estimation and compromise ourselves, telling it's acceptable and it should remodel. So for the past 2 years, you'd be hearing to these words. If you fail to plan, then you're planning to fail. So this is a case where the patient had a severe osteoarthritis of knee. The patient had, following a trivial injury, had a distal tibia fracture. So we had operated this patient, and following the surgery, we told the patient to get operated for the knee also, but the patient denied it. And following 3 months, once patient started weight bearing, the patient had an implant failure. The primary problem was in the knee. So the second case is a case where there is a complex deformity of the femur following native splinting. So we will be discussing in detail about this case. So the preoperative planning in orthopedic surgery, the current practice and evolving application, what does it help us in? So it prepares the surgeon mentally, so it reduces our stress. It lessens the intraoperative time by 20 to 30% and prevents the anesthesia-related complications, infections, implants, and instruments required. You have to operate virtually multiple times, create a step-by-step blueprint before operating on the patients. Because of this, you will make less mistakes without risking the patient's health. Steps will not be missed, and better outcome of the surgery. As a limb reconstruction surgeon, our aim would be to make the patient a comfortable and stable Elizaro frame or any method of fixation, allow weight bearing as early as possible without any pain, reduce the external fixation time, and early union and rehabilitation. So the preparation of the patient starts from his general health to correct anemia, diabetes, and protein, and to make him quit smoking, alcohol, and steroids. The most prior thing will be to take up any case will be counseling of the patient. So the course of the treatment, the duration taken, the number of surgeries required, the cost, any complication which will occur during the surgery, teach the patient about the apparatus which is going to be applied, and the prognosis of the condition without any hypes for the surgery. So the preoperative assessment starts from history. Clinical assessment and radiological assessment are paramount importance for any case for a successful outcome, and neurological and vascular assessment and documentation is a must. The assembly of the frame I try to do mostly 1 day prior to reduce the time. So intraoperative vascular examination, how to do it. So mostly the skin color changes from pale to blue if there is any vascular injury, cold extremities, feeble or no pulse, the capillary refilling might be sluggish. So even after that you are sometimes doubtful, then a handheld Doppler definitely helps. In some cases it have helped where I do acute docking of the tibia more than 4, so the Doppler has helped. So if Doppler is not available, at least spin prick test is a must. So do not hesitate to call your seniors, your colleagues in difficult cases. So always better to have a team approach. So the basics should always be followed for any deformity correction. So now the aim of orthopedic surgery has moved from the union to alignment. The failure to follow the basic principle of deformity correction results in a poor alignment, which leads on to a secondary deformity, which might be more difficult to correct than the original deformity. So who or what is a genius? Those who analyze the complex problems and finding simple ways to explain in an understandable manner. So there's a great salute to these 3 great surgeons who have been the pioneer in our field. So the deformity correction has been moved from past, we have been using paper-based planning, and now there is many digital apps and preoperative planning is present. Though it is hard to learn, but it takes some effort and practice. So now move on to the case one. This is a 35-year-old female. Here she has a history of trauma 4 years back, so went for a native splinting. So what are the present deformities in this patient? So first will be the varus deformity of around 120 degrees. There is a procurvatum deformity of 140 degrees. And there is internal rotation of the distal femur by 125 degrees. There is a total apparent shortening of 22 centimeter. Soft tissue contracture is present. The knee deformity, flexion deformity, movements of 60 to 100 degrees is present. There is a normal neurovascular status. So the questions for this case will be running around mind: how much deformity and how to correct it, what implant should be used. And mostly we can anticipate any neurovascular injury if you do it correct acutely. So whether to do a gradual or acute correction, and most important will be acceptance of the patient, whether this procedure, if you are going to apply external fixator, whether the patient will be able to, going to be a long process, whether the patient will be able to withstand this condition with surgery. So this is a vascular Doppler CT angiogram, which shows us the level of the femoral artery, how close it near to the osteotomy site to make a proper pre-op planning. So on this type of cases present, do not hurry to do a surgery. It is never important. A successful outcome is always important. So discuss about the case with your seniors and teachers. Do a proper research and find related articles have been reported in literature about the case, how is the success rate, and step-by-step plan for about the case. So the options available will be a gradual correction using Ilidoro method. Sometimes we can use an alpha fixator, it's a uniplanar fixator. And acute correction should also be in mind. So the acute correction plating is difficult, so nailing can be an option. So if going to do nailing, what type of nailing can be done? Antegrade or retrograde nailing. The problem is hip is fixed in abduction and we want adduction for nail entry. It is possible, but with the extensive soft tissue release to bring the hip in adduction. So hence retrograde nailing is a better option compared to antegrade nailing. So we went for a 3D, we give for a 3D printing model. So here you can see the deformity, which is well appreciated. Though in X-rays, more than X-rays, this can be appreciated in 3D printing model, which is taken using a software. So the patient, here you can appreciate the varus deformity, the procurvatum deformity, and you can see the internal rotation of the femur. So the patient actually, the first for priority would be to go for nailing, and definitely if there is going to be any complication, interop, most probably we expect a vascular compromise, then definitely external fixator was also available on table. So piece by piece, wedges were taken and the deformity was corrected. And preoperatively, we applied the nail, which nail we wanted to use. This is the actual size of the bone interop. So the preoperative planning was done accordingly, and the nail size of 25 size retrograde nail was used. So the intraoperative, we marked the vascularity using a mehendi so that it will not be erased after pre-wash. And here first we marked using a shank spin, the rotation, how much rotation is there. That is the proximal femur laterally, and this is distal femur laterally. Then the vascular surgeon was called for. So he explored and he had the control of the proximal vascularity. If in case we are going to damage any vascularity introp, so prior to the starting the surgery itself, vascular surgeon is called and we got a hold of the femoral artery and the profunda femori, and the deformity was completely exposed. And the wedges were taken into 3 piecemeals. You can see here 1, 2, and 3. We didn't take a single wedge. So step by step, we removed the wedge and tried to correct it. So this is the post-op X-ray we were able to achieve fully, and post-operatively, intraoperatively, we used a Doppler to confirm the findings. And the patient is now around 1-2 weeks post-op, she is safe. So the 3D printing helped us, and we were able to mimic and reciprocate what we did in 3D printing, the same nail. We used around 4 screws distally and 3 screws proximally. So this case too, where we used, this case was done by my colleague, Dr. Lakshmi Narayanan. Similar to that, this is a FFD knee, where this is mainly to show you a pre-operative planning and assembly should be applied over the knees. So just moving on to this case. So each case, even in trauma cases, do not miss anything. So use a CT-based scan properly. So these are some of the apps which will be useful for you. So you can take a click of this. So Bone Ninja is the one which we commonly use because of the cost. There are other CareStream software, PeakMed software, and OsteoMaster. So I like to finish this. My final things will be, change is the only constant in life. One's ability to adapt to those changes will determine your success in life. I thank you for this opportunity.
Thank you for sticking to time. That's a fantastic case. I think we'll take the questions later.
Yes.
Really well done.
Yes.
Congratulations.
Thanks.
May I now call the next speaker? Dr. Siddharth.
Dr. Siddharth.
Professor Siddharth Sharma, please. On virtual surgical planning.
Is it on? Okay, thank you, sir. So in the time that we are setting up, we've heard that, failing to plan is planning to fail. Do you know who said that? Benjamin Franklin. Okay. So this is not really a deformity or an Elizrao lecture. It's examples taken from common orthopedics practice, which you could hopefully use. So I'll tell you what is planning, some examples, and then if there are advantages, what are the disadvantages? So like I said, this is not a step-by-step approach, but it is intended to show you the possibilities. And once you've seen the possibilities like the movie Matrix, you would never want to go back to your conventional sort of planning. So we already know it is 2D or 3D imaging techniques, which is used to evaluate complex anatomy, and it can help you guide treatment. So I've divided this talk into 3 sections. How you can use planning for visualization, which we are already doing most of the times. Measurements, which can be oftentimes very precise and very important. And then also virtual surgery, which becomes a little bit more technical. So all of you, I would recommend, should be starting to use DICOM softwares. One of the easily available ones is Horos. There is also Radiant. And one of the things that you can do with CT scans is learn to reformat them or reslice them. Oftentimes, CT scans are not taken in anatomical positions, right? So, for example, if you wanted to classify this intra-articular calcaneus fracture, the book says it has to be, the foot has to be positioned in a certain way. But you can always rotate the axis, make it parallel to the subtalar joint, and do the same thing, right? So the same analogy, the same principle of having the X-ray beam or the line parallel to a joint can be easily employed. Very, very simple thing, very easy to do. Okay. The next common thing that we see is metal artifacts. So metal artifacts can be a big problem, as my colleague from spine gave me this. So is my screw intra-articular? What do I do? So another very common thing available in all of the DICOM readers. So you go to that area of interest. As you can see here, we blow that up. You see the metal artifacts. Okay. So in this module, we choose something known as a minimum intensity projection. So the minimum intensity projection will make sure that only the bone window is seen the best. And then you increase the slab thickness. So slab thickness is basically the slice of the CT. So by just these 2 combinations, now you can see that you can clearly visualize the pedicle, you can clearly visualize the screws, they are not intra-articular, and this analogy can be used for 100 different purposes. Maybe you want to see if your tibial plafond screw is intra-articular, right? And we have published this. You are free to read this article. There are some other tips and tricks there as well. Now, assessment of torsional deformity is, one of the most important things, but also one of the most overlooked things. And you can only do this accurately on a CT scan. And one of the things how we assess torsion is to take the image of the proximal fragment and the distal fragment in the femur, as you can see here, and then do it. And I will show you subsequently how we can do this very, very easily on your common PACS software. So the same way you can assess tibial torsion, and all deformity surgeons should be doing this. So this is a case of a talar neck malunion where we thought everybody thinks that the main deformity is a varus deformity. There was a varus deformity as well. But what about the torsional element? So here we have the section from the talar body and the talar head, which is the 2 things. And then you see Horos has this module where you can pick up this image and drop it to the next thing. You have something called as an image fusion. Now you have a fused image, and what you can do is measure torsion of this image. So the same application can be used for humerus, forearm, femur, tibia, any bone you want, as long as you have a proximal and a distal reference fragment following the principles of deformity correction. Other visualization, 3D scans, we all use, so I'm not going to go here. We have all seen. But a very interesting thing coming up is augmented reality. So I recorded this small video with my iPad. You can have models, project them onto your table, and you can even have markings for your screws. So in the OR, you can project this thing onto the patient's leg and then have this as a rough guide for trajectories of screws or wires or what have you. So measurements are very, very important, especially in deformity correction. So again, Horos lets you do all of this, and I'm sure you've been doing all of this. Bone Ninja is another thing, so if you're not using it already, 2 of our previous speakers have told, you should be doing this. But then there is also something known as GeoGebra. So for those who are not very faint-hearted with technology, GeoGebra can allow you to automate anatomy. So if you knew which angles you wanted to measure, you can actually create an array or a flow, and then with some simple clicks like this, I was able to automate the measurement of tailored torsion. What the software is just drawing all those lines, but you don't have to draw them all over and over again. Just mark a few points and the software will automate this for you. It's freely available, very, very easy to learn. Anybody can do this. How about volumetric measurements? So this was a case of a giant cell tumor that got infected, was managed in an Elizra. We wanted to know how much graft or graft substitute you would need in this case once the infection settled down. So again, I use Horos extensively. It's also available in Radiant. But this tool allows you to just mark out the defect. So you mark it out on as many slices as you can, right? And once you do that, it actually calculates the volume. It also gives you a 3D model to show you what that thing would look like. So if you wanted a block graft, you can shape it. If you want the total volume of the graft, you can actually plan how much graft you want to take. And volumetric measurements are now being used to assess even things like syndesmotic instability. So let's move on to virtual surgery, and I will keep it simple, although we have very advanced software now. So one of very simple things is something known as Sketchbook. This is freely available. And the residents should be using this very easily. So here we have a depressed intra-articular calcaneal facet fragment. With this software, you can easily trace it out. Okay. Actually, perform the fracture reduction, as you can see here. So you are all jogging through the reduction steps in your mind. And you see how much you need to rotate it. So that's also a very handy thing. And then just have the image of a plate. You can scale it down, see it, and this thing then becomes very important. So it gives you a very, very good idea of what your fixation would look like. Again, freely available at no cost. Virtual osteotomy, this is Bone Ninja. Everybody has seen it, so I'm not going to go here. But this is virtual planning in 3D. This software is called Mesh Mixer. Again, comes from Autodesk. Free to use. If you have a 3D model, you can actually create an osteotomy site as many times as you want. And you can align, move about the fragments, and it works on the same principle as the Bone Ninja. You need to define where your hinge is. You can angulate, translate, rotate in whatever way you want. Now coming on to the last thing. This girl came to us with a post-traumatic foot deformity. The radiographs showed that she had a talar neck non-union or malunion. The CT scans showed us some problem, right? There was some dorsiflexion, varus. But what we did here really is to create 3D models. We took the opposite model, the normal side and the contralateral side, created mirror images, and now what you're looking at is 2 3D models superimposed on top of each other as mirror images. And what this allows you to do is quickly see the type of deformity. So there is dorsiflexion, varus, and torsion. So now we are thinking in 3D. The same analogy can be used for our deformity planning in long bones. So here, after looking at the deformity, we were able to get a very good correction and a very good result. So the pearls, we all know that you need to learn segmentation. You need the actual CT data. The pitfalls is that it does take time. There is a learning curve. Do not rely on 3D models because sometimes the measurements can be off. And if you are modeling a fracture, the fracture fragments can be lost. So the upcoming thing is a 4D model which puts the factor of time along with the 3D model, right? So this is a must, and as John Herzenberg says, I will end here, measure thrice, cut once. Thank you for your question. This is the list of software that I've used in the presentation. Thank you.
Well done. Thank you. Thank you for sticking to time. We will definitely have many questions for Professor Siddharth. We will have it at the end of this, in midway between this session. Next is Professor Shakti Das on Elizarov and crooked deformities of the lower limb.
Good morning. My topic is Elizarov method in crooked deformities of the lower limb. I found what is synonyms of crooked. These are twisted, winding, tortuous, many types of synonyms are there. Last 2 days, I think we are discussing everything. But I think crooked, I mean, maybe deformities, maybe very severe deformities. So there are many methods are available with us. Growth modulation, wedging cast technique, osteotomy, JES, bracing, casting, orthosis, soft tissue release, tendon transfer. Many methods are available for deformity correction. But we are discussing here today the Elizarov method. Many times when you attend a deformity clinic, you saw many types of cases, genu valgum, genu varum, and also many types of deformity due to bone contracture, post-traumatic, due to recurrent CTB, many types. See, pseudo tibia. In India, tibia deformities are much more post-traumatic. These are the cases you come across in OPD. But anything deviating from the normal anatomical limits in terms of angulation, rotation, translation, shortening, or any combination thereof, is a crooked deformity. So causes are either skeletal abnormalities, soft tissue abnormalities, combination of both. Causes are congenital, traumatic, infective, nutritional, arthritic, growth abnormality, rickets, and tumors also. So principles are all the deformities present in a particular case should be addressed simultaneously if possible, in the simplest method with least complication and best possible end result. 6-axis deformity correction, already many plannings and everything has been discussed. So we have to plan it perfectly. We have to understand the deformity of the lower extremity. For that you have to know the normal parameters, malalignment test. So map the ABC, mechanical axis, analyze angles, pick the bone, find out the apex, bone cut, correction either slow or one stage. So levels may be diphyseal, metaphyseal, or epiphyseal. So it has to be planned perfectly, whether there is a single cora or multi-apical deformity and mechanical axis and cora by the normal bone or joint line, you have to assess it. So rules already discussed, hinge point must be on the correction level, and where to place the hinge already discussed in the last paper. So these are some of the rules you have to follow during the deformity correction. So level of deformity, degree and magnitude, type of deformity, plane of deformity, everything you have to assess. So order of deformity correction, angulation, lengthening, rotation and translation. X-ray, full X-ray, lower limb X-ray is necessary. All full set of instruments should be in your table. All the armamentarium should be there with you. For example, this is a case of tibial hemimelia. These patients, they mostly move on their knees. So this is a 10-year-old child came to us with congenital abscess of tibia. So soft tissue release, then Elizarov ring application, hinges placed. So starts yesterday, I think, doctors from Egypt presented also. So then he had done the first decentralization, then distraction. Now we are distracting first. Then in the end, open the knee joint, centralize it, open the ankle joint, centralize it, and limb is now straight, and the child is able to move with the orthosis. This type of deformity is also very common. You have to plan it perfectly, whether in the femur or tibia. I called it O deformity. Planning all the axes, you have to plan perfectly, full X-ray. Femur, I think If apex is only one, interlocking nailing can also do well, no problem. Tibia, here 2 axes and Iliajaro ring applied with the proper planning and method. And now both the limbs are straight and the family are very happy. Post-traumatic. So they are all managed with all the types of fracture correction with the plastic surgery, and you see the problem. Many axes are there, you have to calculate perfectly. These are the correction stage, then the child is able to move with the plantigrade foot and straight knee. Calcaneum foot, maybe neurological problems with this type of deformity, then same principles are affected, then deformity is corrected. These are the various deformities in India. You will get all compound fracture tibia with very many deformities will come across. So then you have to plan it, see already ankylosis of the ankle joint. And you have to plan it, then osteotomy, then correct it. Similar case again, similar case, pseudoarthrosis tibia, already discussed yesterday. You can correct and it unites. Severe type of club foot also, correct it. This is a case of deformity of the tibia. Malunion tibia, you see the foot, how the limb is looking like. If you plan it similar way, and both the tibia as well as the foot, both can be corrected. And these are the crooked deformities you find. Many angles, this you can see already. A femur case has been already has been shown in the morning. So here, due to chronic osteomyelitis, acute osteomyelitis during childhood, this tibia is not already observed. So then you plan, apply. It may take 2 or 3 sittings to reach the end product. First, you achieve something, then slowly, second surgery, and the limb is straight, and the boy is able to walk. Many type of knee deformity, arthritic deformities also come across. You can correct. So complication, there may be recurrence, knee stiffness, neurovascular injury, pin tract infection, persistent pain, many hurdles will come. Posterior tibial subluxation, distraction of the joint, undercorrection, bending of wires, many things you can come across. And once you train perfectly, then you can manage everything. So always after the frame removal, we do a casting for some days. But always remember, therapy should continue during all phases of the treatment. To conclude, Iliajaro system provides a versatile fixation system that gives stability, soft tissue preservation, adjustability, and functionality. A preoperative plan is essential. Careful selection of patients and adhere to the strict pre- and post-operative regimen of deformity correction avoids early and late complications. So steps for the youngsters you can do: train yourself, get the cases, plan with patients, teamwork, therapy, bracing, assess perfectly soft tissue, bony, degree, skin condition, capability of yours and your team. Then you will able to do the deformity correction. This is not a very great job. Thank you very much. So I all seek your support for the IOCON 2025 at Bhubaneswar. Thank you very much, sir.
Thank you. Thank you, Professor Shakti. That's a fascinating series of cases. And thank you so very much for sticking to time. We'll have Q&A session at the end of this. I now request my colleague, Professor Pritish Singh, to speak on healing patterns of acutely realigned corticotomy in coronal plane deformities around the knee. I do apologize to the speakers. The morning session dragged on. We carried over from yesterday. A lot of people have flights, and therefore there are important orations and other important talks. That's why we have to at least definitely stick to our time. You've been given all of 9 minutes. So please do accept any apologies for rushing you.
Thank you, Chairperson, sir. Good morning. I will be speaking on healing pattern of acutely realigned corticotomy in coronal plane deformities around knee. So conventionally, gradual correction maneuver is done at corticotomy level. It involves some latency of 7 to 10 days, and it is said that it ensures better reason rate and probably better healing also. But gradual correction is a tedious process. It is time taking, and it increases overall fixator period by a week or say 10 days. And acute correction is proposed as alternative with optimal healing or say parallel healing in corrected position. So just to assess the acute clinical impact of acute corrections, it can be assessed using 3 criteria: quality of bone union, actual decrease in fixator period, and functional outcomes thereof. So with using these 3 criteria, we did a study, thesis rather, with an objective of assessment of bone union in acutely realigned corticotomy cases in coronal plane deformities around knee. It was a prospective observational study in the during January 2022-2023 in a teaching hospital, and we included patients with only coronal plane deformities around knee, which were treated by Ilizarov method, and software-guided realignment device was used for achieving bone realignment in these cases. So 32 consecutive deformities with coronal plane deformity around knee were evaluated, and with minimum follow-up of 12 months. There were bilateral cases, 11 cases were bilateral. And mean age of patients were 15.5 years in a range of 12 years to 22 years. Genu varum were 4, genu valgus were 27, or there was some other offloading limb alignment costotomy in 1 patient. Tibial deformity was done in 4 cases, femoral 25, and combined in 3 cases. So acute correction was done using Ilizarov ring fixation and software-guided realignment device, any hexapod, using 2 ring assembly and 3 fixations, 3 either pins or wires in each ring. Corticotomy was done in a standard fashion and planned as nearer to cora as possible clinically. Acute correction was defined as no latency or less than 24 hours. So realignment was started within 24 hours, even in post-op period. And final correction was decided clinically as well as radiologically. So bony union was assessed using modified Russ score, modified radiological union scale for tibia. It is based on 2 criteria, visibility of callus and visibility of fracture line. And each cortex is given a score of either 1 to 4. And overall score is, maximum score is 16. A score of 11 was counted as union. So mean correction period was 3.2 days. We started on day 1, and within 2-3 days correction was achieved using that hexapod device. And it in the range of 1 day to 8 days with standard deviation 1.67. And deformities were either requiring angulation, translation, or angulation. Rotational component was not corrected in any of the deformities. So bony results. Bony union was achieved in all cases. There was no case of non-union or any complication of the non-union. And modified Russ score, there was consistent rise in modified Russ scores. And in first month it was 8.27, and at the around say 3 month, it was 14.83. Asami bone results was also excellent in all cases. There were no adverse events with respect to neurovascular structures or with respect to union, or there were pin site issues were faced in 3 cases, which settled using normal means. Terminal joint stiffness was felt in almost all cases, but it weaned off at the end of 1 month. And preoperative range of motion of that joint was achieved at the end of 1 month after fixator removal. Few case examples. 14-year-old female, she was treated by distal femur corticotomy and acute realignment. So there is gradual increase in, say, modified Russ score, consolidation of the at corticotomy level, and at the end of, say, 12 weeks, there was union. Patients were followed at interval of 1 month. And this was the union in the lateral view. And these were the final scanograms. Another case of Genu varum. She was treated with a proximal tibia corticotomy and gradual consolidation at the region corticotomy level. And it was uneventful. Again, in the lateral view, this was the healing in the lateral view. There was slight translation at the corticotomy level, which was unintended and probably was another observation was done that anterior cortex was last to consolidate in most cases. There was consistent delay in consolidation of anterior cortex, and it was ascribed to either surgical trauma to anterior cortex or dilution of corticotomy hematoma anteriorly, or in some cases there might be, say, negative impact of synovial fluid if there was any injury to synovial membrane, including it. With respect to shape of callus, none of the callus was atrophic or concave variety. It was a good callus in all cases. One case was of this fusiform callus, which pointed towards either, say, periosteal injury or, say, periosteal elevation. If we go by literature on similar cases, so there are 4 methods of acute correction described in literature. Implantless corrections with correction by cast only. You do corticotomy or osteotomy and do acute correction. And you can do fixation with plates or fixator assisted corrections, as many speakers told earlier, or fixator only corrections. So in these, I reviewed all articles in all those 4 methods, and union time was 9 to 25 weeks. It was comparable to my study, and in my study it was nearly, say, 12 weeks, 10 to 12 weeks. Except in a couple of cases it was more than 16 weeks also. And complication profile was also similar to literature. So I could conclude that acutely realigned corticotomy and Ilizarov fixation in coronal plane deformities around knee gives predictable corrections, accurate corrections, reliable union, and functional outcome is also optimal. It gives better cosmesis also, being minimally invasive, and it do not require big incisions for plate and extra things. And correction can be titrated postoperatively also, so it increases accuracy. And correction can be titrated to nerve stretch and the pain threshold of the patient. And there are no retained implants in the body which requires a removal at later stage of life. Thank you.
Thank you, Professor Pritish Singh. Thank you for finishing in time.
Thank you, sir.
Let's go ahead to Dr. Amar Soni for minimally invasive quadriceps plasty. This additional time will give us more time for Q&A, and I'm sure a lot of interesting talks have generated many interesting questions and thought processes, so keep your questions ready.
So, for most of activity of daily living, 125 degree of flexion is adequate, and 67 degree of flexion is required in swing phase of gait. But whenever there is an extensor leg, even 5 degree of extensor leg increases energy expenditure quite more. So how this stiffness occurs? I am talking in context to trauma, that following distal femur fracture, whether it's open fracture or closed fracture, also ligament reconstruction, femur release or limb lengthening, and post osteomyelitis. And which are the places where adhesion occurs? The first one is between patellofemoral compound and suprapatellar pouch, between rectus femoris and shaft, and during subcutaneous places. So before we go how to gain the knee motion, we should know how to prevent it so that this requirement of quadriceps plasty doesn't occur. So respect soft tissue, address mechanics to give adequate stability, and early rehab. I've seen many cases where in spite of good fixation, patients are not allowed to start knee bending from first post-op death. And if you are using Elisa, try to use quadriceps sparing pins. These distal femur screws, which are on anteromedial aspect, even if they seem to be of appropriate size, they are longer because the slope of medial femoral condyle is such, and they significantly hamper the knee motion. And if you have done good fixation, at the end of 1 week, you should be able to achieve 90-degree knee flexion following distal femur fracture. You can see here 2 examples. One should avoid anterolateral and anteromedial half pin in distal fragments. Otherwise, patient will surely have knee stiffness. Your pin configuration should be such that patient should gain at least knee motion to 90 degree. And these are different quadriceps plasties suggested by Bennett, Thompson, Judith, Wang, and Cerqueira from Brazil. I'll be talking about last one. This Thomas and Judet plasty issue with this is it requires large incision. Chances of skin necrosis are very high, and wound adhesions are extensive. Exposure, it requires 3 to 4 units of blood, and chances of infection are there. And in spite of all effort, many a times patients do not get adequate knee motion. This method which I'm going to speak is given by a Brazilian doctor, where he uses a midline incision, but most of our patients have previously operated cases, so you can use that lateral parapatellar incision also. First step would be to do a medial and lateral parapatellar arthrotomy, followed by breaking adhesion in suprapatellar pouch and between patellofemoral compartment. And then third step would be to isolate the rectus femoris, and you should isolating rectus femoris, followed by cutting the vastus intermediaris muscle. Once this is done, flex the hip and gently flex the knee, and you should be in position to achieve at least 90-degree flexion with gentle manipulation of knee. And do not forcefully manipulate. And if you are getting suboptimal motion, doesn't matter, but don't use force, otherwise you may damage extensor apparatus. Surgery is done mostly in spinal without tourniquet. Most of cases doesn't require blood transfusion, and I don't do Z-plasty of rectus femoris. One can use an epidural catheter or femoral catheter or post-op pain relief. First or second day, you can use CPM. Otherwise, active knee bending is encouraged from next post-op day, and equal emphasis on active knee extension, no forceful passive stretching, and generally patient stays in hospital for at least 2 weeks so that we can monitor their progress. Adequate counseling is must. Avoid cases where there is a bony fusion between patella and femoral condyle. Avoid cases with extensive skin scarring, and whenever a knee is long-standing stiff, you should avoid, and they are not good candidate for corticoplasty. This is the most important part. Success of corticoplasty depends on whether rectus femoris escaped the injury, how well it can be isolated from scarred quadriceps, and how well it can be developed by active physiotherapy. So this was a case where someone had promised him that I'll be giving good motion, and attempted a corticoplasty and failed, and ultimately there was a litigation for that. That patient came to me for corticoplasty. I simply refused that you will not get any knee motion post corticoplasty. I'll go through some cases. This patient was having a segmental femur fracture treated at Bangladesh, and fixation was done, and at 6 months he presented to me with stiff knee. I did minimal invasive corticoplasty, and I did some changes in screw configuration, and eventually at 6 months post revision he gained functional range of knee motion. Another case, very communicated distal femur fracture with a floating hip, floating knee, treated with a plate. Eventually at 2 years he had stiff knee, which was treated with corticoplasty and gained a functional knee range of motion. Another case, 33B3 injury treated with CC screws, presented to me at 9 months post-injury with varus and stiff knee. I addressed both varus and did a corticoplasty also, and eventually he gained good functional knee range of motion 5 months post-op. This case had some complication. Patient was having subtrochanter non-union, which was treated with Elizor, and at 13 months he came to me for corticoplasty, and there was a rupture of quadricep tendon from upper pole of patella, which I was forced to treat it with tension band wiring. So forceful flexion is not recommended, but eventually he gained functional range of motion. Last case, distal femur fracture treated with Elizaro, stiff knee, did a quadricoplasty, gained good knee range of motion. So first step would be to prevent knee stiffness. So respect biology, adequate stability by addressing mechanics facilitates early rehab. If you are not allowing knee flexion post-operatively, that means you are not confident of your fixation. Adequate counseling and motivated patient gives optimal outcome post-corticoplasty. Goal should be realistic. Never promise patient more than 90-degree or full range of knee motion. Take utmost care to prevent rupture of patellar tendon, patella or quadricep insertion. Thank you. Thank you, sir.
Thank you. Thank you very much, Dr. Amar Soni. Wonderful talk. We'll have many questions for you. Thank you so much for more than sticking to time. Let's go ahead to Professor Jayant Sharma on his talk on genu valgus correction with Elizaro. I really appreciate many of you who are finishing before time. We will have enough time for question and answers. Ideally, we should have immediately because it's fresh in the mind and so many excellent talks today. So we're really looking forward to a feast of the Q&A.
Okay. Nowadays, a lot of young girls coming to us for correction of genu valgus, not requiring the long surgical scar or some implant inside. So we are seeing a lot of patients of, not very much, but genu valgus in our OPD practices. So genu valgus is a common angular deformity of the knee which is seen in children, and then by age of 11 years, the 6-degree valgus is fixed for the knee joint, which is considered as normal. Any deviation from this of the mechanical axis is considered as genu valgus, and we should not forget doing a thorough clinical examination in these cases to rule out any anteversion or tibial torsion which is associated with this. And we consider a case of genu valgus only when the mechanical axis runs 4 mm lateral to the knee joint, the tibiofemoral angle is more than 20 degrees, and the distance between the malleoli is more than 10 centimeters. There are various options of treatment, and first of all is the first one is a watchful observation if the child or the patient is coming at a younger age to us. The indication of surgery are if the tibiofemoral angle is more than 15 degrees and the intermalleolar distance of more than 10 centimeters, and there is a rapid progression of the deformity after the age of 7 years. You have guided growth, hemiepiphysiodesis, and various forms of osteotomies like closed wedge, open wedge osteotomies, or a dome osteotomy, which are fixed with K-wires or DCPs, and we definitely have Elizaro and 6-axis like hack support in our hands to do the fixations or correct these deformities. When to do femoral and when to do a tibial correction is an important thing that you should be addressing to. It is advisable to correct the bones with deformity based on the analysis of LDFA, that is mechanical lateral distal femoral angle, or a MPTA, that is mechanical proximal tibial angle. While the distal femur is the most common site for genu valgus correction in our situation. You have to do a malalignment test, although this picture is showing you a varus, but the malalignment test principles: draw a mechanical axis line from the center of the hip joint to the ankle plafond, then measure the LDFA for the femoral contribution, then measure the MPTA for the tibial contribution. Lastly, you have to consider the joint line conversion angle, which is normally 0 to 2 degrees and with a medial convergence. After this, if the MPTA is more than 90 degrees, it is a tibial component which is to be corrected, and if it is less than 85 degree LDFA, you have to correct the femoral deformity. So, in nutshell, seeing on to the left-hand side, if less than 87, then you do a femoral correction. If it is more than 87 MPTA, you do a valgus correction. So, Through Pele method, osteotomy plane and the scora of the femoral valgus are confirmed. In patients with the epiphysis is not fused, according to Pele's multiplier method, you have to add on to the maturity difference in the limb length so that you don't end up with a limb length discrepancy. So decide where the deformity is, decide whether the deformity is uniapical or a multiapical deformity, mark the cora and measure the angle between the two lines. This is one of the example cases of femur. The osteotomy is done at the cora, hinges are placed exactly at the position, gradual distraction, and this is the patient walking after the correction. The other side is still waiting. Meanwhile, the girl got engaged, so she's not interested in getting the other side operated. Another case, sorry, I don't have the clinical pictures and the functional picture of this patient. So coming on to a tibia, in tibia you take a small longitudinal incision, and just like you do a correction of HTO, you have to do a osteotomy at the level of deformity, and you have also to do a fibula osteotomy, thereby you do a correction. Hexapod I've used only in one case, because coming from a place where Ayushman is very much available, patients don't prefer going for the other method of expenditures. Hexapod is a software assisted, the accuracy increases, it is patient friendly, but costly because neither Mediclaim clears the bill of Hexapod nor the Ayushman. This is the new thing which I was going through the literature and found it to be quite interesting, because when you're doing a femur Ilizaro and the rings on the proximal side definitely give a problem in patients lying down, etc. So a hybrid fixator has been devised by Tanmay Mohantri. It was published in IJO Trauma and Reconstruction, in which he has devised a special clamp to be attached to the proximal ring, and through which he is fixing it with the LRS so that the turning of the patient and lying down on the bed is better. I thank you for your kind attention.
Now the next speaker is Dr. Ishani. Her topic is extensive lengthening in achondroplasia.
So we are going to take the liberty of extending the QA session for at least 15 to 18 minutes, since many of the speakers have very kindly finished 1 or 2 minutes each before time. So keep your questions ready.
Very good morning. I'm Dr. Ishani Chaudhary, and today I'll be taking you through extensive lengthening in achondroplasia. Now, achondroplasia is the commonest form of short-limb dwarfism, with 1 in 25,000 births as incidence, where the trunk is normal, but the limbs are shorter with a skewed upper to lower segment ratio. This is caused by a defect in the FGFR3 gene, which leads to typical features of achondroplasia. Here are the facial features. And in the upper limb, there is incomplete extension of the elbows, trifid hands, and short stubby fingers. In the lower limbs, there is bow leg, that is upper tibial varus, reduced rotations of the hip, which does not let the patient sit cross-legged. Now on the X-ray, chevron-shaped metaphysis, overlong fibulae, tibial varus, and coxa breva with high trochanters is seen. These are the spine features. There is delayed chondrocyte maturation in the hypertrophic zone of the physis, which reduces the longitudinal length or the growth of the bone, but the length of the muscles is normal, which gives the potential for large amount of lengthening. So we start off with some cases. This was one of the first cases at our institution. A 13-year-old girl presented in 1991 with 3 feet 11 inches height. Dr. Chaudhary did a bilateral bifocal tibial lengthening for her. In 13 months, she gained 14 centimeters and her varus deformity was also corrected. Now, with experience, we like to start lengthening early in achondroplasia because age is on our side. Now, The question was when to lengthen, right? Why do we lengthen early? That's because the younger children integrate the fixator faster with the body and their movement, and the growth potential is higher, which allows maximum length gain. Now here is an example of a 5-year-old girl. Bifocal tibia lengthening was done for her. Her bone growth was so fast and good that we achieved good length, and she developed lateral popliteal nerve palsy. So we had to stop that for the nerve recovery, which happened completely, did a repeat corticotomy for her premature consolidation, and resumed the lengthening. She gained 11 centimeters, which was 88% of her entire lengthening, and then proceeded to a humerus lengthening. Next stage, she got cross lengthening done for both sides, and her total length gain was 33 centimeters. And the best part is that she transformed from a dwarf to a normal. She's now happily married and also has a child. This is our common strategy for lengthening in achondroplasia: bilateral tibia and then bilateral femoral lengthening. Here is an example of another child. We started off with tibia lengthening. Once that was completed, went on to femur lengthening. She gained 11 centimeters and good function. Now then we proceeded to humerus lengthening. Her treatment was completed, and she's now independently driving a 2-wheeler and also a 4-wheeler. I'll try to play the video for you. She came for a follow-up in the OPD last month and happily told me that she is newly married and has been working in the MSCB department, the Maharashtra State Electricity Board department, for the last 5 years. So from these examples, we learn that early lengthening in achondroplasia helps with good functional rehabilitation into the society. So what happens if we wait or if we start late? Here we encountered some problems. For example, in this 12-year-old boy, we gained 15 centimeters in under a year, but he didn't wish to get a second stage of lengthening. He got 15 centimeters, but he's left with this appearance. And we found that older children tend to be not so psychologically compliant. So, how much to lengthen is the question. So lengthen maximum safe possible. There is no predefined amount or number to start with in the mind. Just monitor the entire process and check for nerve and joint function throughout the process. Sharing our results. We achieved an average of 60% lengthening in the tibia and 50% in the femur and humerus each. These were the amounts of lengthening in a single stage. The external fixation index was approximately 1 month per centimeter in all the segments. We did not face any atrophic regenerate problem, only 4% regenerate fractures compared to 30% which has been reported in the literature by Song et al. Due to excellent regenerate formation and capacity, the lengthening capacity, the premature consolidation is seen in approximately 10% of the cases. And in less than 3% were left with limb length discrepancy of less than 5 mm discrepancy, none more than a centimeter. These were our knee joint complications. Axial deviation was the commonest complication, only 3% having deviation more than 15 degrees. In our series of 42 achondroplasia lengthenings, these were the amounts of lengthening in a single stage. Currently, there are 5 cases in different stages of their treatment, undergoing treatment at our institution. In conclusion, I would like to state that extensive lengthening in achondroplasia is possible and safe, allowing them good function and integration into the society. I thank you for your kind attention.
Thank you very much for finishing in time, Dr. Ishani. Let's request the next speaker, Dr.
Abdelal Hussein from Egypt. His topic will be treatment of genu varus with posterolateral corneal instability by Elizaro.
Okay, good morning, everybody. Okay, treatment of the genu varus with posterolateral corneal instability. The long-standing varus deformity of the knee increases the varus movement arm about the knee joint. So, the excessive tension across the malalignment knee often cause the lateral collateral ligament, the popliteofibular ligament, and the popliteus tendon to stretch out and fail over the time, resulting in posterolateral corneal insufficiency. This will often lead to functional instability, which may show as a varus thrust gait pattern. So, surgery should aim to address all elements of instability. the mechanical axis of the knee and the reconstruction of the posterolateral corner to allow the patient to return to a near normal level of function. So correction of the mechanical axis is essential to decrease the resultant lateral compartment force, and the reconstruction of the three important structures is the basic goal of anatomical reconstruction of the posterolateral corner. Although there are several techniques that address varus and posterolateral instability, it's still technically challenging to reconstruct all these structures with isometry, as any reconstruction should be isometric in all angles of knee flexion and knee extension. So we hypothesize that gradually moving the fibular head distally with correction of the genovarus will result in indirect tightening of the attenuated posterolateral corner ligament. This depends on that the lateral collateral ligament have an insertion in the head of the fibula, and also the popliteal fibular ligament has insertion on the head of the fibula. The surgical technique, we did high tibial osteotomy, open wedge high tibial osteotomy, not a closing wedge, but that after applying a construct of 1 ring or 1.5/8 ring proximally and 1 or 2 ring in the middle segment of the tibia. Then resection of the fibular block about 1 to 2 centimeters from the middle of the fibula, and the amount of resection is determined according to the joint line conversion angle plus 5 millimeters. Then we transfixing the proximal segment of the fibula with one wire 1.8 and two strands 3.5 millimeter on a 5/8 ring through the tibial frame. This is a 5/8 ring connected to the proximal segment of the fibula, and we add a distal tibial ring with transfixing wiring tibiofibular ligament to prevent the subluxation of the syndesmosis. We begin to gradually moving the head of the fibula distally by moving this 5/8 ring distally. We continued descending the head of the fibula until obtaining a docking side in the compression, and do more compression to obtain a union of the fibula. So these illustrations for the application of the frame, So the results, we have improvement in the corrected mechanical axis of the tibia at near normal joint line convergence angle, improvement in joint line convergence angles, and the patient had sufficient improvement in knee function with a stable single leg stance. So how did that happen? Labrat reported that 33% of the patient improved with an opening wedge osteotomy without ligament reconstruction if the posterolateral structure were lax and not completely disrupted. So, an opening wedge osteotomy had the advantage of tightening of the posterior capsule and the popliteus, which can ultimately foster additional posterolateral stability. Why? Because the origin of the popliteus lies in the posterior aspect of the proximal tibia, and in the opening wedge osteotomy, we increase the surface area of the popliteus, which the popliteus be more tensioned. The lateral collateral and the correction of the attenuated ligament. Actually, 33% is not more. There is more than 60% need a help. Correction of the attenuated ligament can be achieved by direct reconstruction or indirect tensioning of the direct tensioning technique. Larson repair using semitendinous graft is the most frequently used to reconstruct the lateral collateral ligament and the popliteofibular ligament. But it is still technically challenging to reconstruct this structure with isometry, as we said. So, indirect technique advanced the insertion of the important structure, posterolateral structure, by moving the fibular head distally, can achieve tensioning of this structure with isometry. So, this can be performed acutely or gradually, but we prefer the gradual, do it gradually, because gradual transport avoids a large surgical exposure and release of the proximal fibula with its risk to the peroneal nerve. So, using a Lazarov system that is based on biological law and technological philosophy in correction of the genovirus with proximal tibial opening wedge osteotomy and indirect tightening of the posterolateral corner simultaneously will create sufficient clinical improvement and subjective stability, which can allow the patient to return to a near normal level of function. So, in any case, the understanding the biological essence and the mastering the method of Elizarov will provide the orthopedic surgeon with more freedom and flexibility in actions and safety. So, Elizarov didn't leave us just a device, but a philosophy which has been and remain lifeboat in the most complex case and many subspecialties. Okay, I hope to see all of you in Cairo next July in our International Skeletal Deformity Correction Congress. Thank you very much.
Thank you very much, Dr. Abdullah Hassan. May I request Professor Junjunwala, sir, we will have the question answer sessions first, and then we will have you with the, so may I invite all the speakers to come on the dais? Professor Zhang. We'll start with the question answer session. We can have the questions. Please be brief with your questions and address them to the speakers. The speakers may come on the dais if there is time, or they may answer from wherever they are. You can come up, please, Dr. Prashant, Dr.
Speaker, please, speaker.
Subramaniam Gandhi, Dr. Ishani. Yes, you can ask the question, Professor Bari.
Where is Omar Sani? My question to Omar Sani.
He may be in the other hall. If you have some other question, you can shoot that first.
Ishani, my question to you, how many times you have done the lengthening of this achondroplastic patient?
So all the recent cases that I have shown, the 5 that have come in the last 2 years, I have done the tibial lengthenings in 3 cases personally, and the other 2 I have participated in.
And re-lengthening in the same tibia, no?
So in the last 2 years that they have come, we haven't had an incidence of that.
Thank you. Omar Sani, you know the quadriceps plasty, Judetes, we are randomly doing 5-step surgery that was written everywhere. But your technique, you don't feel any problem more than when you are doing Judetes quadriceps plasty, 5-step surgery, medial, lateral, rectus femoris, and proximal release, anterior fascial release. Even you can get more than 90 degree. But in your cases that you have shown more than 90, I have not seen. And what is the trick of that, your technique, this?
Sir, I agree. I don't say that more than 90 is not possible, but forceful flexion should not be there. And in Judette, I agree that you can get more than 90 degree motion, but many of patient loses those motion, while here the patient doesn't lose his motion, which we get during surgery. One thing. And second thing, the amount of blood loss, scarring, possibility of infection, all are very less. And all patients do not have adhesion at this much level. So we need not erase this quadriceps muscle from linea aspera in every cases. So most of adhesions are at distal level as compared to shaft level. And releasing a straight head of rectus femoris is rarely required, what my observation is.
There is a modification of the Judetes. You do the proximal release, distal release, and traction over the patella. There is a Chinese publication. They are doing lots of cases of this knee stiffness. Yes. Do you have any idea about that?
No, sir. No, sir.
So, very interesting observation, Dr. Amar Soni. I invite more questions also. This is a very good technique, but I suppose we have to go case by case in the sense, depending if suppose somebody has had an Elizarov fixator and there is a lot of scarring even proximally, we may not be able to address.
When there is an extensive scarring over whole length of thigh, then this technique would not. This technique is mainly useful for distal femur fracture stiffness.
Correct.
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 Not from all Elizarov patients.
Correct. And this, just to add to the knowledge of the participants, this is a technique described by Rob Rosbrook, who was shared his talks with us yesterday. During the femoral lengthening, he does a minimally invasive cordyceps plasty while the lengthening is in progress to improve the range of motion. So that's also something interesting to remember. And you were saying something is not necessary in all cases for rectus. I would go as far as to say never touch the rectus.
Yes.
Never ever touch the rectus.
That is prerequisite in rectus. So I have never released rectus femoris.
Great, great. So if there are any more questions, we'll take, or I will. My question to Professor Shakti Das, your really interesting and very challenging cases with significant rotational and all kinds of angular deformities. How often do the patients follow the, can comply with the follow-up regime and come for the appropriate changes needed for the fixator in your experience?
Most of my cases I demonstrated are from a Government of India institute where everything is free. So I think most of the patients, they report regularly and follow also regularly. Only they have to, their transport expenditure only, otherwise they usually come without any problem.
My very general question is, do you have a designated time and technicians and staff available for the follow-up visits of these patients?
No, we and our postgraduates, basically that unit which operates it, we follow the patients. There is no designated time or no designated. Once we give sometimes patient, they may come little bit late but they come. Once, for example, if a laser or engage in the body, they cannot go anywhere. They will come. At least for removal also they will come. So I think follow-up is not a problem for me. I have not faced any problem, mostly.
Great. That's very heartening to know. We also have Professor Ranjit Kumar Borua, sir, who also, for years and years, he conducted this in our government medical college successfully. I really give my great respects to all of you. Now, if I may ask the question to Dr. Prashant. The question to you, a very nice exposition of the oblique plane deformity.
Sir.
And can you please explain how would you also lengthen after you analyze with the graphic method? How would you also add lengthening to the deformity correction? If you can explain to the audience. You showed very nicely with the graphic method analysis where to place the hinges. So if you also wanted to lengthen along with correction of the oblique plane deformity, how would you place the hinges?
So there are two ways actually. So one is a graphical method, and other is the X-ray method. When you rotate the limb, the maximum deformity where the tibia is the axis where you apply the hinges. So when you actually correct the deformity and the hinges have become normal straight away, then you can just lengthen it.
Lengthen all the threaded rods.
Yeah,
And is there any other method of the placement of hinges? Yes, Dr. Amar, would you like to?
So we can place hinges little away from convex border. So
Correct.
that will need to not only deformity
Correct.
correction but lengthening also.
Correct. So in the line of the plane of the deformity which you analyzed on the graphic method, perpendicular to that line, on the convex cortex, you'll just create an opening wedge. If you stay in the center of the bone, as you go more towards the concavity, in the center of the bone, it'll create angulation translation. If you stay on the concave cortex, you can resect a triangle. If you go further down the concave cortex on that line, you can shorten and straighten. And if you go away from the convex cortex based on that planning, you can place the hinges to perform the lengthening in a very elegant manner. Really nicely done. Thank you. My question is to Dr. Subramaniam Gandhi. It's a fantastic case.
Thank you, sir.
So please tell us all the precautions you took on the table. Did you have a standby Doppler?
We had a vascular surgeon intraoperative, sir. So he first did the surgery. What he did was he opened the vascular femoral canal, and he got hold of the femoral artery and profunda femori. So it was under his control. So he didn't knot it. So he just had a visionary of it. So if in case during osteotomy, if he had any bleeding distally in the osteotomy side, so he will already have a hold of the proximal femoral canal area. Other than that, we had an intraoperative Doppler also available. So Doppler also we used intraoperative after everything, and postoperative also we checked using Doppler, sir.
Okay.
So
So how did you compensate for the length, could you manage to accurately calculate the length and how much length you would gain and how much length would you lose in this method?
So we used around, we lose around 6 centimeters of length, sir, totally. So most probably we have to compromise on length at present. Once the patient has a good mobility, 6 centimeter is not going to be a problem. After later stage, we can do a LRS or so, we can do a lengthening. Removing the nail, we can do a lengthening after that.
Or lengthening over a nail?
Lengthening over nail can be done.
Great.
Because this was a case of massive deformity, we didn't want to take the risk of doing lengthening also. It will be a too much ask about the pay for us to do the lengthening and to do so much deformity to be corrected at the early stages. So I didn't want to go for lengthening at present.
Great case.
Thank
Great case. There's a question to Professor Abdelal from Egypt. Please do not mind us saying, we have all tried using this pulling down the fibula method. Maybe your technique is much better, but we found that after some time, the ligaments tend to stretch out after some time. And there is more laxity. Again, we can see laxity. What is your experience? And I would invite answers from the audience, from the experienced surgeons as well. Please.
Actually, I have 3 cases with the return of the laxity. Okay, so we go to do more tensioning. So okay, we at the first I was calculate. At the first I was calculate the block segment according to the joint line conversion angle. Later on, I plus 5 millimeter to do over tensioning to avoid laxity later on.
Did you do any radiological study to find out how much the fibula came down immediately after fixator removal and after, say, 6 months or 1 year? That would be interesting to know whether the fibula migrates up again. And did you do anything like fuse the fibula to the tibia in its new position with a screw or something like that?
I will try.
Okay.
Okay,
That would be a good observation too.
Thank you.
Professor Lakshmi Narayan. So please tell us about the case you did.
Yes, sir.
And whether you had difficulties in performing the second stage correction. Do patients agree for the second stage montage with the complex Elizaro that you put on? And do they agree?
I did it single stage only, sir.
You did it initially.
Single stage. It's around 73 degrees of recurvatum in a fusion knee. Anteriorly, skin graftings were done at the childhood. So there was only skin and bone. So there is no opening anteriorly. So medially with small incision and laterally small incision, I elevated flap slowly. I completed the osteotomy without injuring anterior skin. Because if the skin is open, osteotomy site is open to outside. Everything will fail. And if the osteotomy goes posteriorly, the night before the surgery, he just asked me one thing, doctor, if the deformity is not corrected also, it's okay, but just don't let my leg amputated. That's the stressful condition, but I dared it and I do osteotomy very slowly. And later on, it's simple deformity correction only. No stretching of neurovascular structures because they are posterior. It's actually no stretching there. So if we do the osteotomy perfectly, the case was cakewalk.
Did you find that the regenerate took much longer to heal or something like that?
No, sir. He did not wait even 1 day to walk. It's around 3 months for correction, and he walked for 6 months more. The regenerate was solid. There was no hypertrophic regenerate, anything.
Okay. Dr. Ishani, can you please tell us something about, that there are advocacy groups for achondroplastics in Europe which strongly advise them to undergo lengthening to improve their life. And there are advocacy groups in the USA, for example, they call the Little People's League of America. They do not encourage them to have lengthening. So what do you think should be, in a country like India, what is ideal? Should they be advised to undergo lengthening? Is this such a good thing? Will it help them with their lives?
Thank you very much for the question. This allows us to put forward a good strategy. First of all, the thing is that, number one, I have a couple of people who are now friends from this case series. First thing is that there is not much awareness about this condition in the general population and the fact that they can be treated. One of the things is I would recommend that they should undergo lengthening. Uh, with the they should undergo lengthening, but the thing is that as an orthopedic surgeon treating them, it is advisable not to over-promise them, number one, not to promise them outrageous amounts. Second thing is, I do recommend giving a lot of supportive therapy in terms of physiotherapy, active physical rehabilitation, as well as mental and psychological rehabilitation, because these people are rare and unique, so they do need that. So if we have a good support system and if we can operate on these people with good technique in a safe manner, I do advocate lengthening in achondroplasia. Thank you.
Thank you. I just want to add one point for information of everybody. Now in India, dwarfism is a disability. There are like a blind person, like a, any deformity, orthopedic deformity. Dwarfism is itself disability. There is a calculation for it. In more than 40%, somebody can get all the benefits from the government of India, also job and everything.
Yes. So we do have patients who have definitely gone back and returned their disability certificates as well. So yes, thank you so much for adding, sir.
Maybe please call upon the speakers to accept this, sir. Please.
After this wonderful session, there is a token of appreciation, the memento will be given. I invite Dr. Milind sir and Dr. Shakti Das sir to please give memento to Dr. Chunjunwala sir first. I invite Dr. Prashant. Dr. Subramaniam Gandhi. I invite Dr. Milind sir to give memento to Dr. Shakti Das. Dr. Priti Singh, is he here?
He's taken a break. We'll give it to him in the next
Yes.
session.
Then Dr. Ishani, please. Dr. Sati sir will give a memento. Dr. Mohammad Hussain, yes. Thanks. Yes. Last. Sir, Dr. Amar Soni. Dr. Amar Soni, sir. Thank you. Thank you so much, sir. Thank you so much.
Dr. Lakshmi Narayan, please.
And Dr. Lakshmi Narayan. Yes.
Thank you all very much, speakers. Now may I request Professor Jhunjhunwala to proceed with his talk. Thank you.
Good morning to all. I'm going to talk about the oblique plane deformity. If you see this bone in AP view, it looks like that. There is a deformity in the mid shaft. And if you rotate it to 90 degrees, that is in lateral view, you will see the deformity. But there are no two deformities in this bone, but there is only one deformity, which is oblique plane deformity. So if you rotate it, and when you see the maximum angle, that is the oblique plane deformity between AP and lateral or AP and lateral deformity. Angular deformity may occur in any plane. The standard deformity planes are two anatomical planes, that is one coronal plane that is in AP view, what you see the angle, and in sagittal plane, what you see in the lateral plane. But oblique plane deformity is between two. What you see in anteroposterior and lateral views are wrongly referred as biplanar angular deformity. These biplanar deformities are actually uniplanar angular deformity in an oblique plane. So in AP view you will see 20 degrees angle, and in lateral view you see 34 degrees angle. So in 90 degrees plane there is no deformity at all. And in plane of maximum deformity is 50 degrees. In AP view you can get varus or valgus deformity. In lateral view you can get procurvatum or recurvatum deformity. So it is one must know what is the deformity. Perpendicular oblique radiograph obtained with the beam in the line of the plane of angulation shows no angular deformity. Oblique plane deformity is in between coronal plane and sagittal plane. Dore Palais has written a book on principles of deformity correction and explained all the deformities. What is an oblique plane deformity? How to identify the oblique plane deformity? How do you analyze the oblique plane deformity? How to quantify and deformity, that is to find out the magnitude of the deformity. And last thing is to find out how to correct this deformity. The magnitude of oblique plane deformity and angulation angle can be found out trigonometrically or by graphic method. Graphic method is easy, and angular deformity can be corrected by a single plane axis with single planing. So how to find out the deformity? So you take a AP view. So find out the anteromedial is the direction or deformity, as the apex is medial on AP view and apex is anterior in lateral view. The apex of the deformity here is here and apex is here. This is the anterior view, this is the medial view. So you draw a line and you draw a vertical line 90 degrees to this and draw 1 centimeter point here, 2 centimeter, 3 centimeter, 4 centimeter, like that, 1 centimeter, 2, 3, 4, like that. And so this is in AP view 20 degrees, and this is valgus angle. And in lateral view it is 34 degrees angle, and it is a procurvatum angle. So you know it is valgus. Now this is a left foot is drawn here. So this will be the medial side, this will be the lateral side, anterior side and posterior side. So it is a valgus angle. Therefore you take 20 millimeter point here and 34 millimeter point here because it is a procurvatum and apex is on the anterior side. So apex is anterior side, it is 34 millimeter line here. So this is 20 degrees and a line is drawn here. This is 34 degrees, a line is drawn here. And a oblique from this point to this point, it is 45 degrees by measurement. So your oblique plane deformity is not 20 degrees or 34 degrees, but it is 45 degrees. And then you draw this line, extend it. So you get and take one ring which you are going to use. So this is the ring which you are going to use. Put it there on the paper. And then you know that this hole, the posterolateral third hole, is your point which you are going to fix up. And then you draw this is the tibia, this is the leg, and this is your point where you are going to fix your hinge. No, not hinge, distraction rod. And this is the tibia. Touching to the tibia, you draw a right angle to this line. So this hole and this hole, your hinges. The hinge automatically will come here. The hinge point will come here. Hinge point will come here. And the hinges will lie in the center here, so that you can get your oblique plane deformity is 40 degrees and it is 55 degrees in coronal plane. So bring your scale right angle to that and then draw a line. So that you get those two holes for the putting your rod of the hinges. And you get posterolateral third hole is the distraction rod. Now, for the deformity correction, you must use olive wires. And where to use those olive wires? If you draw a stick and you want to make it straight, how you do it with your thumb and fingers, what you see in this figure. So where there are thumb, you have to put olive wire from this side, and where there is index finger, you have to put the olive wire from this side, so that when you do deformity correction later on, there is no sliding of the bone. So you can see that olive wires are put here. नहीं है क्या? Pointer. So you can see here there are two olive wires and two olive wires going from this side. इधर उधर नहीं आता है यार. Weak है, weak battery. And then you put your distraction rod. Sure. So this is the distraction rod, and these are the two hinges. This is the hinge, this is the hinge. If you put these hinges at the level of the cortex here, then you get a opening wedge like this. Now, this is your point, this is your point, and these are the two, this is the distraction rod. Now, your aim is you have to open 1 millimeter at this level. And how to open that in 1 millimeter, because you have already put a distraction rod here and two hinges here. So you have to calculate hinge to the distraction rod. You measure the hinge from this hinge to the distraction rod and hinge to the anterior cortex here. So hinge to the distraction rod and hinge to the convex side of the bone. So whatever it comes, say here it is 4 inches and it is 1 inch. So that means it will come 4. This will come 4. So you have to do 4 millimeter lengthening every day. This distraction 4 millimeter. Then only you will be able to open 1 millimeter at this level. So these are the other sections you can see here. Because it is a valgus in epiview, recurvatum in the lateral view. So according to that, you have to change your angle here, and you know what is the exact oblique plane deformity. This is another graphic representation of varus and procurvatum deformity. This is another recurvatum, varus and recurvatum deformity, and some oblique plane deformities. Just another deformity in between coronal and sagittal plane. Measurement is commonly done from X-rays using graphic method. Irizarro ring fixator or 6-axis correction give the best result. Thank you.
Great. Thank you, Professor Junjunwala, for this very elaborate exposition of oblique plane deformities. Let's move ahead with the program. Can I call Dr. Sudnetsin, Professor Sudnetsin from Russia? I'm not sure if he's there. So may we go ahead with Dr. Noras Linda from Malaysia on the Valant process in limb reconstruction. I hope we've pronounced your name right, ma'am.
I just press here. Assalamualaikum and very good morning. I'm the Dr. Nur Hasina from Malaysia. So evolution of Walan in limb reconstruction related procedure. What is Walan? Walan is a wide awake local anesthesia, no tourniquet, meaning there is no sedation and patient doesn't have to go routine pre-operative testing. This Walan technique been started by the Lalonde more towards the soft tissue procedure at the upper limb and also the fingers. It's been throughout the world, been using it for the soft tissue procedure, and lately it goes for the fracture fixation at the upper limbs. And they also, in this Walan technique solution procedure, you can communicate with the patient during the procedure, and also you can ask the patient do an intraoperative active motion. And the complication regarding the lidocaine and epinephrine was being talked about it, and so far there is no complication when you use these two solutions. So in Malaysia, there's a few studies using a Walan technique or Walan solution in the cases, for example, more towards in upper limb fracture fixation. In my hospital, we did quite a group, big group numbers. They did a fixation of a distal end radius and also distal end radius and also plating radius ulna using a Walan. In my team, for the limb reconstruction, we have a difficulty to proceed with a small procedure after we did the Elizarov or limb reconstruction procedure. For example, for any skin release or any corticotomy or any chipping osteotomy need to be done, especially during the COVID-19. There's more of the procedure for the general anesthesia is towards to the emergency or life-threatening procedure. So because of this, we are thinking of why not we using Walan to accommodate our procedure, small procedure. So the same solution that we use for Walan in other procedure that they did before, so we do in our procedure. So most of the solution we injected to the whichever the area that we want to proceed with the procedure, but we must wait at least 15 to 30 minutes so that the solution can work better, so we can have a proper procedure during that time. So most of the time we need imaging intensifier to help us to locate where is the procedure so that we can minimize the time and the patient can have a better pain control during at that time. And most of the time, the important we can communicate with the patient, asking the patient whether they have any pain, and at the same time, we can ask them to move the leg and also the toes. So another procedure is the skin release. Sometimes it's normal when you have a very bad bone large defect, which is you can't really can help the plastic surgery to help us for the flap. So in between the ongoing the bone transport, they might have a skin invaginate between these two when the bone transport region and to the docking site area. So using a Walan technique, Can you can move give your a leg? proper solution which is not more than 40 minutes, and we can proceed with the Do you have any skin pain right release now? so that it can accommodate during the transport process. How about this one? And also the chipping osteotomy. We also did the same thing. We give a solution. We injected the solution where is the area that we want to produce the procedure. And at the same time, we can ask the patient whether they're having a pain, and at the same time, we can ask the patient to move their toes and also their legs. The challenge is when we do at the femur. Because it's very soft tissue, the soft tissue is very thick. To get the solution reach to the bone is very difficult. So what we did is we use the angiocatheter needle so that it can reach the solution, can give up to the subparietal region, to the peripheral part of the femur, so that we proceed with for example, for corticotomy for the lengthening. We evaluate the pain score for the patient, for each the patient from the before the procedure up to the 6 hours after the procedure. So during this COVID era, so we managed to get 10 patients to go under this procedure under Wallan technique. So most of the patients up to the 6 hours, the pain score is less than 3. So even though the COVID is now manageable, and even we still doing it, Wallan, especially in the daycare patient, so that patient can come early in the morning. We do the procedure, the small procedure, and then at the noon we can discharge the patient with a pain score less than 3. So the conclusion in my presentation today is Wallan is a good alternative and successful option for surgical procedure to be done apart from general anesthesia. During the pandemic COVID-19, is most elective surgical procedure due to prioritization given to the emergency and COVID cases. So we shift the total anesthesia workload towards the intensive care away from the surgeries. So the lower limb post-reconstruction procedure is a procedure that need to be performed at a specific time to achieve a good result for the patient to be able to perform their activity of daily living independently. So this Wallan technique, or using a Wallan solution, is a significant dilution and solution to the first combination in lower limb post-reconstruction related. So this is my Wallan team in limb reconstruction study in Hospital Tunku Jaafar, Seremban, Malaysia. Thank you. And last but not least, we are coming to be a host for the 7th Combined Congress Asami Limb Reconstruction System on the 27th to 30th August 2026. Please mark this date. Thank you very much.
Thank you, Professor Noras Linda. Very innovative solution. Thank you. We will have questions for you. May I now request Professor Mufakul Bari, our friend, to give us his talk on Blount's disease.
Stand. So, Chairman Sir, my fellow colleagues and young stars here.
Oh, start.
Okay. Yes. So I would like to share my experiences regarding the bow legs and the Blount's disease. I quickly want to proceed. Just I will show you this is the center. This is our study. I showed you. Now I am working in a very big hospital, diabetic, with the diabetic foods and infections and ulcers. This is my center. Now you can see here impossible to reality. These are the cases that we are facing all the time in our country. So various types of Blount diseases you can see here. Let's see this one, types of bow legs, understanding the varieties. And again, we should not give up and we should not allow the problems to defeat us. So here you can see here, this is we're doing workshop, and 1 year back with Professor Shepsov in our Dhaka place, in our center. So Elizarov effect, you must keep it in your mind all the time. Blood supply increases 330% after putting the Elizarov apparatus. So Blount's disease, I don't want to elaborate everything, only I will just go for this hemicondylar osteotomy you can do, you can see here. And see the angle measurement is very important, tibiofemoral angle and the metaphyseal diaphyseal angle before going for any kind of Blount's disease surgery. So these are the exercises, you know. Now you can see MDA angle and you must measure all these things. Elizarov mathematical formula, you should know everything. So this is the disorder of proximal growth plate medially causing progressive varus knee malalignment in children and adolescents. The early onset of walking and obesity and bilateral is always more than unilateral. So causes, I don't want to go. See, this is the clinical feature similar to physiologic genuvarum. Obese patient, often lateral thrust on walking. Now, these are the angles, lateral subluxation of the tibia. Look at these at the medial side, medial slope epiphysis and widening irregular fascial line medially, varus angulation, epiphyseal-metaphyseal junction. Look at these, the classification. You know all these things, 6 stages, starting from 2 to 3 to 10 to 13 years. Now, prognosis, not accurate for non-whites. Stages can occur earlier in non-whites, can skip stage and progress to a stage 6 in non-whites. What's in black girls? No data on Bangladesh population. So, stage 1 and 2, you can see here, and stage 1 and 2, stage 3, corrective osteotomy, metaphyseal alone, delay in surgery, higher chances of recurrence. Stage 4 and 5, more serious. And stage 4, medial body bridge and epiphyseal closure. And you can see the X-ray here, bad X-ray and good X-ray. So, players in decision making, these are the things: vast severity, age, articular depression, unilateral, bilateral, or shortening of the limb. Now, treatment, early osteotomy of the tibia. Why Elizarov, you know all. And postoperative management and rehabilitation is very important. And so what are our known knowns? There are known knowns. There are things we know. There are unknown unknowns. That is to say, we know there is something we do not know, but there are also unknown unknowns. And once we don't know, we don't know. So, dear friends, always the challenges in your life, you will see the easy, difficult, and impossible. I love to do the impossible cases. So now let us share some cases. 2-year-old girl, Blount's disease, stage 2. You can see here only the Elizarov wires. I have done this, and you see after the 3 months radiographic view during treatment, and this is the final result. Now you can see the 2-year-old boy, the Blount's disease, again with wires, with rings, and this is the treatment after the 4 months follow-up. And case 3, see, sequelae of Blount's disease with bowing of the tibia with genuvarum, 24-year-old girl, beautiful girl, came to me with this situation. Then she was walking like that and started doing treatment. This is the radiographic view, and this is after removal of the apparatus with plaster, and this is the final condition only after 7 months. And after 9 months follow-up, you can see from that situation to this situation. So these are the cases that you should handle. Look at this 7-year-old boy with Blount's disease, and then corrected only with the wires and the corticotomy in the below. And this is after the removal of the apparatus, and this is the final follow-up. Look at the X-ray before and after 11 months of the follow-up. And this is before, and this is after. And again, another one, you can see 20-year-old girl, Blount's disease, Elizarov fixator, radiographic view, before, after 7 months treatment, and this is what are the bow legs. Now, you should have to differentiate between the bow legs and the Blount's disease. So this is the bow. What are the symptoms of bow legs? You know, all the Elizarov surgeons are sitting here. And what are the risk factors for bow legs? You know also that. And then you can see, I would like to share this full type O bow legs, 11-year-old boy. See how he was walking. And this is the only, you see a double-step, two-level corticotomy, and the wires fixation, and the Elizarov ring, gradual distraction, and this is the final follow-up after 8 months. See, from that situation to this situation. So this is after removal of the apparatus. Again, one very difficult case, use the lower limbs, 50-year-old boy. You can see here, radiographic view. And this is after 2 months, after 3 months, and this is after 6 months. This is the final 1 and 2 years follow-up. And this is also bilateral bowing femur. Look at this. She was walking like that, and during treatment, and this is the final follow-up from that situation to these situations. So this is the final one. You can see how the beautifully corrected only after 6 months. again, this bowing femur and tibia. And this is the another case you can see here. I have done here the chondrodiastasis. At the age of 15, I took it as a challenge. I did not do any kind of osteotomy here, separation of the EP metaphyseal. And as a result, you can see here the good outcome and good results only after 6 months. The same case, bow legs, all of the bow legs after 5 months follow-up. And this is again, you can see here the hypophosphatic ricket, 5 and 8 years old boy. Same with the players. I'm playing only with the wires, no pins here in the tibia and femur all the time. And see after 6 months follow-up, and this is the final follow-up after 11 months. So complications, common parallel nerve palsy may happen, compartment syndrome, anteriotibial anterior artery occlusion may happen, recurrence may be, but I have not seen in my cases, and I have the publications in the American Medcrave Mojo Journal of this regarding this. And whoever saves the life of one person, it shall be if he had saved the life of the mankind. So these are the cases that we are doing. So in cosmesis and deformity correction, correcting the correct deformity at the correct coda based on correct planning and the correct method to achieve the correct corrections. So this is confidence is better than perfection, because perfection means doing the best, but the confidence means how to handle the worst. So, dear friends, whenever you apply the Elizarov apparatus, you must have very good rehabilitation center do what they are doing. With clumbing, the Elizarov in the femur, lot of orthopedic surgeons, they are telling this is the cumbersome for the femur. But you must have a special cord, and you must train the patient how to continue the exercises. See? And I am just telling my patients, do the exercises, and in instructing the patients, they are doing these are the special cords for the femur. You must have recess. And there is no joy in possession without sharing. A hand that gives in a rose still retains in fragrance. So purpose driving line, challenge is always in your orthopedic surgeons. They're facing lots of challenges in life. And friendship has no borders. With curiosity, you are never tied down, only tied together by the experience of traveling, sharing new methodology with each other. And I love to do that. And see the Asamicon, I see here, the 2022, all Indians are here, Professor Junjuna sir, Ruta Kulkarni, Milind, everywhere. And this is the last, I have published since 2006, 8 books and 103 international publications, and most of the in American journals and Russian Kurgan journals. And I am the reviewer of PhD theses and DSc theses. And last, what this is, I love to show this message all the time. What I show you, this is the evidence, dear friends, and science, of course, the surgical skill of the surgeon. And what is the peace, perfect endeavor around the countries of the earth? You can get it by doing Elizarov surgery. Thank you so much for your kind attention.
May I invite Professor Vikas Gupta to give his talk on coronal plane deformities. He's scheduled to be in the next session, but he has a flight to catch. So we'll have him, please.
Thank you, sir, for adjusting my talk due to the logistical reasons. I'll be speaking on the coronal plane deformities around knee, which you all know is the commonest malalignment seen by all of us. The treatment is dictated not only by the age, but as well as by the underlying pathology. So the question comes, is it a physiological alignment, leave it as such, or observe, or a pathological alignment, which is a malalignment, which needs to be addressed? So to understand that, we must understand this graph given by Salinas and Banka in a study of large number of growing children, which show that child is born with a pronounced varus, overcorrects into pronounced valgus by the age of 4 years, and it's only by the age of 7 to 8 years he has a normal physiological alignment. Okay? So based on this graph, if we draw these angles, tibiofemoral angle and intermallar distance, and draw two standard deviations, we come to the conclusion that a knock-knee deformity in a child less than 7 can be safely ignored or just observed if it is symmetrical with intermallar distance of less than 7 and tibiofemoral angle of more than 12 degrees. So we can say convincingly a child more than 7 with intermallar distance of 10 needs further investigations to find out the reason behind this valgus deformity. And a child more than 3 who normally does not have a varus with intercondylar distance of 5 needs further investigations for the varus deformity. And we subsequently published this review article. Okay. So we all know that natural history of lower limb malalignment is not benign. And I say it is a pre-arthritic deformity which leads to abnormal loading of the joints with early osteoarthritis. So what are the management options? Either observation for the physiological varus or valgus or the surgical. I'll come to the surgical part. Now this 5.5-year-old boy with an intermallar distance of 18 centimeter definitely needs to be investigated for the underlying pathology and which turned out to be active rickets with low vitamin D. So before you do any intervention, you need to have the medical management. So we followed him serially with x-rays as well as blood investigations, and after 3 months, there was a complete radiological resolution, as you can see. But when he showed up at 6 months, the deformity persisted with 17 centimeter with abnormal LDFA. So what should you do? Leave it or go for osteotomy? The best option is growth modulation. So as Heisenberg says, the best osteotomy is no osteotomy, if possible. So growth modulation is a unique technique. We all know that, those who have been doing it, simple, safe. So what we did this 8-plate and followed him serially with x-rays as well as clinical measurement. So once the deformity was fully corrected, as you see, the mechanical axis is well aligned to the center of the tibia. We removed the plates and he is being followed up for any recurrence or relapse. Okay. Now, is there any severity of deformity, any contraindication for the growth modulation? Definitely no. Even age is not a contraindication, as Stevens has done in a child as young as 1.5 years. So this boy, 4-year-old boy, had a very severe deformity, as you can see, about 32 centimeter. And when we followed him serially, he had a complete correction. In fact, we went for slight overcorrection. And that's after 2.5 years, and you can see the gait. So there is no contraindication for the severity of the deformity. Now what about the osteotomy? So we can have acute correction or gradual correction. So I'll show you the need to correct the mechanical axis deviation is dictated not only by the symptoms, but as well as the position of the mechanical axis. So if we draw the mechanical axis, zone 1 is zone within the tibial spine, zone 2 is zone within the tibial condyles, and beyond that is zone 3. So angular deformity correction is indicated if mechanical axis passes through zone 2 with symptoms such as pain, or even if patient is asymptomatic, the mechanical axis is beyond zone 3, it should be tackled. Okay. So this girl, 16-year-old girl, we did the malalignment test, and one can see there is a abnormal LDFA on the both sides. So where is the deformity? A distal femur is the deformity. We planned according to this malalignment test. We found the cora was juxta-articular. So what we did, we have devised this osteotomy, originally described by Agliti, which is, we termed it as a V osteotomy. It's a vaginous osteotomy, which we have published subsequently and has been now done by most of my fellows and students. A short animation will show how we do it. Actually, what we do is make a V in the frontal plane. So it's a vaginous, you don't need to remove any bone. And you complete this with the osteotome. And with gentle thrust, varus thrust, the deformity is corrected. So like this. Now these are the some, just go fast due to paucity of time. Now it's a simple technique and you check the alignment with an alignment rod and fix it with a customized buttress plate. And finally you do the alignment test with a cautery rod or alignment rod. And that's the post-op X-ray, and that's that picture. Okay. And we subsequently published in this JBGS case series, case connector, where you can see the technique also. So coming to the last example of a gradual correction. So you have this child, 18-year-old boy. he fell down from a tree about 6 years back. He had a progressive deformity, shortening, as well as abnormal thrust. As you can see, he has a multiple deformities, shortening, varus. So not all varus is in the tibia. You do the malalignment test. So what we found that LDFA was 117 degrees. So deformity was in the femur, lower end femur. So magnitude deformity was 30 degree. The shortening was about 4.5 centimeter. So best option what we see, and we had a workshop yesterday, is the software aided correction using DefFix or any other frame which you are familiar with. So these are the operative steps. This is the technique which I have devised for doing femur ilizero. I bend the knee joint by placing a temporary wire which is connected to the end of the fracture table. So you have the maximal stretch of the quadriceps. And then you proceed with the standard fixation method. And this is the osteotomy which you have done. And you all know this, it goes through the various parameters. I'm just forwarding it fast. And you get the correction schedule. So that's after 3 weeks, the frame is stable enough. So that is distraction wedge, as has been alluded earlier. It's not an angular wedge, it's a distraction wedge. And that's after 6 weeks. And after 4 months. And he has a complete correction, shortening as well as the varus correction. So another case example, multi-complex deformity of shortening, varus, as well as tibial torsion. That's our gait. Again, you have to plan. Now, planning has to be done. The software will not do the planning part. You have to input the data, so both the hardware as well as the software data. So this is the planning you have to do. You must understand the deformity, the map, the ABC. I think most of you know. And that's during the follow-up. And that's the final correction. So what is the take-home message? The natural history of the physiological deformities such as genu valgum or verum is of spontaneous resolution. So parents must be adequately counseled. So for that, you must understand the natural history. The natural history of pathological deformities is often not benign, and they tend to progress, which can affect the gait function. And remember, the deformities with tibiofemoral angle of more than 15 degrees and distance of more than 10 centimeter in a child more than 10 hopefully will not resolve spontaneously and need to go for some kind of intervention. The goal of treatment is to restore normal, well-aligned mechanical axis. Guided growth, I think those who have not done it can try. It's a very attractive, safe option for correction of angular deformities in growing children, provided the epiphysis, the physis is open. And reserve osteotomies for children near skeletal maturity, which could be acute correction or a gradual correction using ilizero. So thank you very much.
Thank you, sir. Next talk will be by Dr. Milind Chaudhary, sir. He will be talking on double level fixator assisted nailing.
Good morning. We've seen a lot of talks on children's deformity corrections. When you reach skeletal maturity and when you have complex deformities in the limb that need to be addressed at the same time, this is a technique we've developed over the last 15 to 20 years, double-level fixator assisted nailing. It got published in the British Journal of Bone and Joint Surgery in 2019. The instruments that we need for DLFAN are custom-made straight nails of the perfect length and diameter, polar screws, rigid straight cannulated reamers, proper entry point jigs, and a wide diameter of the C-arm. This full-length X-ray is a sine qua non. It's not called a scanogram, please. This is a teleoröntgenogram or a full-length film. It's not an orthoröntgenogram. This is a teleoröntgenogram or a full-length film. Next, we need a wide diameter of the C, especially in the lateral view, when we need to place the polar screws or when you need to properly lock the nails. We have these straight nails which have been designed specially for us with extra holes in the center by Uma Surgicals. These are the rigid reamers that we have of different lengths of the flutings, along with the simple old style rigid reamers that we use for Kunsha nailing. We use these polar screws which help to narrow the track of the nail and ensure that the nail goes in the desired direction. And some of the rules that we use are the ones described by Rob Rosbrook. This is the reverse rule of the thumb when using intramedullary nailing. For entry point accuracy, I have designed these jigs with the help of Manman. This is in the lower end of the femur, which will help to achieve the perfect ALDFA of 81 degrees, because the nail goes in the anatomical track, and this is the entire set designed by them for us. You have to look at the length and the diameter of the nail very carefully. You choose the portal. You cannot perform a proximal entry in this case because of the significant bowing, and you cannot adduct the limb. So you can't go in from the proximal end. In this particular case, with the extensive valgus, you would hit the femoral head and neck, so you can't get a proximal entry. You have to choose a distal entry. In these two cases, we will find on the one on the right, there is a fish mouth deformity. There's a fish mouth deformity on the right, so you can't go in through the distal portal. And over here, there is a patella baja, and there's no space between the patella and the femur to get an entry into the femur. So you have to carefully look into this to determine where you're going to go. The next thing to look at is the osteotomy location and the placement of the central holes in the nail, since you want to perform two tasks in one segment using a single implant. That is the target over here. So when we perform, say for example, a case like this, with this kind of genu valgum deformity, you look at high quality full length x-rays, and this animation should kind of show you the type of correction that we achieve. We start by drawing the angles. This is his, MLDFA. We place the pins posterior to the track of the nail. Then we have this jig that allows us to pass the guide wire and reamers at 81 degrees. We place polar screws around it, then perform the osteotomy. With the help of the reamer and the pins, we correct this at the lower level. At the upper level where it intersects, we perform the second osteotomy. Typically, it's more in procurvatum. And then, pass in the nail, lock it, and remove the fixator. So these are some of the pictures. These are the pins. This is the special instruments we designed. This is the place where we located the osteotomy. These are the polar screws, and it helps us to correct. These are the clinical views of this. Helps us to correct the deformity. The tibia gets corrected with a medial translation of the distal fragment. In valgus, always lateral translation of the distal fragment to achieve a good correction. In a similar manner, the other side was done, and he has achieved his full correction with full range of motion. We are reliably told he came on television and gave back his disability card because now he can do everything and doesn't need to be called as disabled. In double level varus, in medial compartment arthritis like this, we analyze the deformities at 2 levels, and we can do this in a similar manner. I won't show the video for brevity. And this is how she's on one side. It's a double level correction with the nail, like so. This is a medial translation in the varus. This is a TCVO, which I alluded to on the first day. In a similar manner, the second side was done in the femur, and a double level correction of the tibia, the TCVO intra-articular as well as a focal dome distally, to help her achieve a full correction, complete resolution of the deformities, and full function as well. This is a pediatrician with severe procurvatum deformity, which forces him to walk with his hand on the thigh. You can see with careful calculation, this is a double level procurvatum, and hence we have to perform the osteotomy at 2 levels like this. Near the knee joint, it's important to translate it posteriorly. This is the rule 2 of deformity correction, and it enables them to walk straight without having to bend forward or to put a hand to the thigh. So here he is after the correction, and then a supramalleolar osteotomy to correct his equinus to allow him to walk well and spend minimum amount of energy while walking. We can use this in post-trauma cases, non-union with shortening. We pass in a nail from the distal end. This corticotomy for lengthening, nail is kept free, always the LRS mostly, to achieve lengthening, and the non-union automatically heals without lengthening. Within a few weeks, this is his range of motion. As I was saying about supracondylar osteotomy, the previous osteotomies translated the distal fragment anteriorly, giving rise to problems. This is how we do it. And even with the nail, we can achieve double level. This is for lengthening. This is the supracondylar osteotomy. The central holes lock the nail, achieve the length. These are the polars that narrow the track of the nail in this plane. This is how we do it. This is the polar over here, and the posterior translation is achieved, which is crucial in allowing him to walk better. This is when we use the proximal portal. This is how we achieve the correction, and at both the levels and achieve lengthening in another patient with polio. This is Ollier's disease with a lot of shortening varus and recurvatum. So we kept the nail protruding at the top by almost 8 centimeters, locked in the center, lengthening and acute correction of the varus as well as the recurvatum at the lower level. The nail slides in and we lock it to give him his full length and good function. We can perform arthrodesis in this lady with poliomyelitis, very severe, instability of the ankle. So we have performed this. The nail goes in from below. We fuse the ankle. We perform a lengthening at the distal level to help her get 4 centimeters of length and a much better gait and stability at the level of the ankle. By keeping it in equinus, you don't have to also correct at the level of the knee. We've had some complications like premature consolidation and also undercorrection, for which you are best off using the fixator. Knee stiffness in this patient, where the nail was a little longer in the earliest series, he needed a quadriceps plasty to achieve full correction of his deformity. This child with cerebral palsy had this correction of her varus and bowing with lengthening, but unfortunately, one of the holes was very close and she went into a severe spasm and she broke the nail. And of course, whenever in trouble, we learned to the mother, which is the Elizarov apparatus, which helped us to completely correct her, correct the deformities, as well as give her the desired length without any further complications. This headmistress of a school with polio had double level, similar ankle fusion and lengthening. The nail refused to lengthen, and then we converted it to the Elizarov and solved her problem. I will end with this example of a radiologist who came with fibrous dysplasia, very significant amount of shortening, like so. We removed the implant in the first stage. This is a nail that has been inserted from distally. You can see the polar screws. The nail is locked over here. We have chosen not to lock in the center. 2 osteotomies, acute correction of the valgus at the lower level, varus at the upper level. We allowed whichever osteotomy wanted to lengthen to that extent. And then at the end, we locked him in both the places. The bone consolidated well to give him an excellent correction of his length as well as all the deformities. Just to paraphrase Marshall McLuhan, we shape our tools and afterwards our tools shape us. With a simple umbel intramedullary nail 2 and with the simple LRS fixator, you can achieve a lot with double level fixator assisted nailing. I thank you very much for your attention.
Thank you, Dr. Milind, for an excellent lecture. Now I request Dr. Ruta Kulkarni for her talk on implant-assisted lengthening. Is it necessary? And what is the recent trend?
Good morning, everyone. So Professor Elizarov discovered distraction osteogenesis and his miraculous circular fixator in 1951. And since then, we are using these to correct severe deformities and limb length discrepancies. But as more and more lengthenings were done, few problems were encountered, like long fixator duration, pain, pin site infection and scarring, soft tissue contracture and reduced range of movements. And all these things led to low patient compliance and low acceptance by surgeons. So many efforts were put in to overcome these problems. So mainly talking about the duration, say for 5 centimeters of lengthening, the classic way, the distraction phase lasts for 50 days or 2 months, and the consolidation phase lasts for minimum 6 to 7 months. For 5 centimeters of lengthening, we need about 8 to 10 months of fixator period. So all efforts were done to reduce the fixator time, and implant-assisted lengthening was introduced. In implant-assisted lengthening, the lengthening or the distraction was carried out by the fixator, and the consolidation phase is taken care of by the implant. So say for 5 centimeters of lengthening, the need for fixator is only for 2 months. So the first in this quest was lengthening over nail, introduced and popularized by Dr. Herzenberg and Dror-Paley. Second was lengthening over plate. Then came lengthening first and nailing, and lengthening first and plating. And the latest player in this field is, of course, the self-lengthening, completely implantable nail. A few words about lengthening over nail. It's a fantastic technique. You can use it in femur and tibia. With femur, you can use it just as LRS. It gives excellent regeneration and very good rehabilitation. Even in tibia, you can use it very easily with Elizarov fixator, gives excellent results. The only problem, the only annoying problem with this technique is intramedullary infection, which is introduced by a pin tract infection. So, utmost care has to be taken to avoid this, and pin tract infection has to be treated radically. To overcome these infections, the Russian introduced this device. It's a very useful device. It's called as extracortical device, ECD. It doesn't go into the bone. It holds the bone circumferentially. So you can do LON using these extracortical devices. But it was the good thing about these devices is that you can introduce them percutaneously, like a shanspin, and you can attach them to the ring with a rancho cube, like a shanspin. But the only problem encountered with these was that they were not able to withstand the severe forces of lengthening, and they had to be aided with 1 or 2 shanspins. So again, we were back to square one. Nailing and plating after lengthening is also a good technique. You lengthen first and then introduce the nail and remove the fixator. Lengthen first, introduce a plate and remove the fixator. It has less infection than LON. It has less complications than LON, as literature states. But again, the potential complication of introducing a deep infection always remains, even with this technique. So the lengthening over plate came in vogue. In this technique, the plate is inserted right from the beginning of lengthening. The problem with this technique was that, I'll show you a few steps of the technique. It goes like this: cut the fibula first, then put the plate on the tibia and mark the site of corticotomy, which is usually below the 3rd hole. Take a small vertical incision and slide the plate on the medial surface of the tibia, subcutaneously, quite easy. Put three screws percutaneously in the proximal holes. At the site of corticotomy, elevate the periosteum, make multiple drill holes, cut the anterior cortex, and then apply Elizarov fixator. 1 ring above, 1 ring below the plate. Here the middle ring is empty. Then the corticotomy is completed by rotational osteoclasis. The problem with this technique was that the plate left the bone and it became prominent and regenerate bent into prochromatum. So to overcome this problem, we introduced this slotted plate. So we put a screw in the slot. The screw goes in the distal fragment and slides in the slot during lengthening. It holds the plate close to the bone and doesn't allow a plate to become prominent and prevents even the prochromatum. The plate is available in 4 sizes: 4, 5, 6, and 7 centimeters. So this is how it looks. Post-operatively, distraction is started, like usually after 5 to 7 days. Weight bearing is allowed throughout. So as soon as the lengthening is done, you take the patient inside, put the screws in the distal holes, put a tibiofibular screw, and remove the fixator. Don't worry even if you don't see regenerate, because in this technique, regeneration is always very, very good. So these are animations which I will skip for want of time. So post-operatively, guarded weight bearing is allowed till we see good regenerate. And usually the syndesmotic screw is removed after 2 months. So I have published this as original article in Indian Journal of Orthopedics. Encouraged with the results in tibia, I started doing it in femur as well. This is a case of congenital short femur syndrome with 15 centimeters of shortening. So I did 8 centimeters of lengthening in tibia with the same technique and 7 centimeters of lengthening in femur using slotted plate. So you can see excellent regenerate here, and this is post-removal. And I have published this again in this prestigious journal of JLLR recently. So coming to the last player, and that is self-lengthening nail. Precise is the most popular nail right now. It is magnetically driven bidirectional nail activated by magnetic field generator. And you can control rate and rhythm of the lengthening. So even the distraction phase is taken care of by the nail. You don't need the fixator at all. Again, Robert Paley popularized this nail quite a bit. In India, it's not very popular for one major reason, and that is cost. It is exorbitantly costly. So I requested Drawer to share a few cases of self-lengthening nail, and thanks to him, he shared. So this is one of the cases of Drawer. This is a case of knee valgus with shortening due to growth arrest. So Drawer used this precise nail and did 6.5 centimeters of lengthening, and then he corrected the valgus deformity acutely, closing wedge with a plate, and he also did common perennial nerve release, and that was the final result. So right now, the precise nail is immensely popular all over the world. Now let's come to the last question. Is implant-assisted lengthening really necessary? Are there any real advantages over classic lengthening? So let's see the literature. I scanned the literature and found these answers. So implant-assisted lengthening has advantages over these advantages. It reduces fixator period, reduces pin tract infections, early rehab, better patient compliance, and it is useful even in pediatric patients. And last one I would like to add, it is very surgeon-friendly also. So this is one old paper by Mark Dahl. He says that plate-assisted lengthening is a safe technique that minimizes time of external fixator, and it can be successfully used in tibia and femur. So this paper also says that it is about lengthening over nail. He says that it prevents axial deviation and allows early rehabilitation. This paper compares LOP with LON. And this paper says that LOP, lengthening over plate, is a safer and more effective alternative to lengthening over nail. And it has absolutely no risk of nailing also, like AVN, fat embolism, and so on. This paper is a very important paper according to me. This is an original article in Journal of American Academy of Orthopedic Surgeons. They have compared 457 classic lengthenings with 488 integrated lengthenings, means implant-assisted lengthening, and they have not included self-lengthening nails in this series. And their conclusion is that integrated lengthening is superior. It has better X-fix index, and it has less complications, problems compared to classic lengthenings. The only concern was deep infections, but only in lengthening over nail. So to conclude, I feel implant-assisted lengthening is superior to classic lengthening. Fixator index is reduced, complications are less, patient compliance is more, and the only problem with LON is deep infection, and especially it should not be used with pre-existing infection. So thank you for your kind attention.
May I now call upon our President, Dr. Rajat Agrawal, to give his talk on cubitus varus.
Cubitus varus. The parents are quite apprehensive about their child, so let's see how we correct it. We published a paper on this on JPOB in 2022. How we define cubitus varus? Actually, it's an inward inclination of a supinated forearm on an extended elbow, and its most common complication of supracondylar fractures in children. There is a varus, hyperextension, and internal rotation of the distal fragment. Usually osteotomy is done in cases when there is unacceptable cosmetic appearance and a functional impairment. The problem is there was inadequate reduction at the time of fracture. There was medial displacement and internal rotation of the distal fragment. In the surgery, we correct this varus tilt and the rotation. Many osteotomies have been described in literature, common being this lateral closing wedge osteotomy with internal fixation, but there are chances of poor cosmetic appearance due to the lateral condyle prominence. Recurrence can be a problem because the tendency of the distal fragment to angulate in varus after internal rotation, and obviously there is surgical exposure. Ilizarov comes as a good solution. It overcomes all these limitations of internal fixation. The most important advantage is it can be a complete, accurate correction because mainly it's a cosmetic surgery. Obviously, it's minimally invasive and you can start mobilizing from day one. So we operated on 32 cases with a mean age of 9 years, 9.2 years. As with every case, you have to do a proper pre-op assessment clinically and radiologically. Clinically, first we measure the carrying angle. For this, 2 lines are drawn between the midpoint of the wrist and the antecubital space and humeral head. With elbow in full extension and wrist in supination, the angle between these 2 lines is the carrying angle. Usually it's 5 to 15 degrees. Second, you have to measure the internal rotation deformity, a technique by Yamamoto et al. You make the child bend forward slightly, place forearm on the back with elbow flexed 90 degrees, shoulder hyperextended. With elbow as a fulcrum, forearm is lifted off the back to have maximum internal rotation of the humerus. Usually in normal cases, forearm cannot be brought up from the back, but in cubitus varus, where there is an internal rotation deformity, the forearm can be lifted off, forming an angle, which is the amount of the clinical internal rotation. Now, when we come to the radiology, the first thing which we have to measure is called as HEW angle, the humerus elbow wrist angle. It is the angle between the anatomical axis of the humerus and forearm. It is measured on an AP radiograph with elbow extended and forearm supinated. How to draw the anatomical axis of the humerus? That's the mid-diaphyseal line. To draw the anatomical axis of the forearm, you have to draw 2 transverse lines, one at the level of the bicipital tuberosity of the radius, and second at the maximum interosseous space between the radius and ulna. And when you join these 2 points, you get the anatomical axis of the forearm. And the angle between this anatomical axis of the humerus and forearm is the point of intersection of the chora and is the HEW angle. You have to take care that the amount of correction needed is the sum of this HEW varus angle plus the valgus angle on the normal side. So suppose if a child is having a varus on one side of 5 degrees and a normal valgus of 7 degrees on the other side, the correction will be 12 degrees. You can measure the lateral prominence index also on the X-rays. It is a difference between the medial and lateral width of the bone from the central mid-humeral axis. Normally it is negative as there is a slight medial prominence, but in cubitus varus it will be positive. You can measure the internal rotation deformity on a CT scan. You have to measure an X-axis, that is a transverse axis of the head of the humerus. From that you draw a Y-axis at 90 degrees, and there is a Z-axis, which is the transverse axis of the distal end of the humerus. The angle between this Y and Z-axis is the internal rotation. There is a patient on the normal side, the angle was 44 degrees, and on the varus side, it was 55 degrees. There was 11 degrees of internal rotation. If we talk about the surgical details, usually we make a pre-constructed frame with 2 fill rings of appropriate size. The distal ring has to be kept at the level of the epicondyles, the proximal ring at the level of the anterior axillary fold. We place juxta-articular hinges anteriorly and posteriorly in the sagittal plane. Hinges are loosened to position the distal ring parallel to the elbow joint line to mimic the deformity, and a distraction rod is placed on the medial side. So we talk about the surgical technique. The first step, the first olive wire is passed from posterolateral to anteromedial surface. Over it, the pre-constructed frame is applied. Then at the level of the proximal ring, second olive wire is passed from anterolateral to posteromedial direction. Then tensioning is done of both the wires. Then a third wire is inserted from the medial epicondyle, posteromedial to anterolateral, and protecting the ulnar nerve. Wire is tensioned. Then with a drill hole of 2.5 mm, we place a pin at the lateral condyle, posterolateral to anteromedial. So we have 2 wires and 1 pin in the distal ring. Then we place the pin. Then in the proximal ring, we have applied 1 wire. We now put a 1 pin We put a one-hole Rencho block with drill bit 2.5 mm drill bit from anterolateral to posteromedial, and a 4 mm half pin is applied. Then again, a second pin is applied with a 2-hole Rencho block after drilling, direction lateral to medial. So, and the pin is applied. So, in total, we have 2 pins and 1 wire in the proximal ring, and 2 wires and 1 pin in the distal ring. Now, before the osteotomy, we have to loosen the anterior hinge and the posterior hinge. And then we do an osteotomy. We first do a drilling, 3 sides, lateral to medial, anterolateral to posteromedial, and posterolateral to medial, and the osteotomy is done. The surgical procedure part is completed at this stage. Now the main part starts in the post-op period. So, yeah. So in the post-op period, the varus is started correction. We do a gradual distraction from day 5 to 7. Usually roughly 3 mm distraction per day at the motor unit corresponds to 1 mm distraction at the osteotomy site, if you can measure it by the rule of the similar triangles. To correct the internal rotation deformity, the distal fragment is derotated 10 degrees by shifting the connecting rods 1 hole clockwise. Usually 1 hole shifting corresponds to 10 degrees of internal rotation. And usually we do it after 2 weeks when there is a little callus formation, because initially we tried in 1 or 2 cases at the time of the surgery, but we got some displacements. So now we try to correct the internal rotation after 2 weeks when it's a little sticky, so to avoid the displacement. In the post-op, when we are doing the correction after final time, the both rings become parallel. This is the time when your deformity is corrected, and you will see a little amount of translation, but that has to be there as per osteotomy rule 2. Then, when the deformity correction is completed, the motor unit is replaced by straight threaded rods, and we do a little axial compression. And as per radiology, the frame is removed. Usually, we have an average time of 3 months. So the patient, about the patients, this is a 16-year-old male with a 38-degree cubitus varus. We applied the hinge. This is the post-op and the final X-ray. And you can see that the thing with this type of surgery is that the patients, the parents, and the attendants are comparing both the hands simultaneously every time. So in fact, they only tell you that now the limb is corrected and you can remove the frame. Another 8-year-old male with a cubitus varus deformity, the post-op final, the before and the after. Mainly it's a cosmetic deformity, so you have to be accurate. That's the main advantage of Ilizarov, that you can be really accurate. So another 11-year-old female with cubitus varus, we applied the frame, the post-op X-ray, and this is the pre and the final clinical picture. Another 14-year-old female with the cubitus varus, we did an osteotomy, the pre-op and the final picture. So for the results, we tried with open hem grading, and we achieved a mean angle of 6 degrees of the valgus. With the Mayo elbow performance score, we achieved an excellent score of 23. Complications, as with any Ilizarov surgery, you will have some superficial pin tract infections. There can be a loss of terminal elbow flexion. This is the actually most common problem we face. In some case, you can have lateral condyle prominence, and maybe there can be valgus overcorrection. To discuss, traditionally, most of the trauma surgeons especially, they go for osteotomy and internal fixation, but there is no scope of post-op correction, and it's a cosmetic surgery. So the recurrence, and there are chances of recurrence due to hardware failure, and in literature, up to 30% of the osteotomy and internal fixation leads to poor results. So many studies have been now published on cubitus varus management by Ilizarov, but in none of the studies we found that how to address this rotational component, which is a significant deformity other than the varus. To conclude, Ilizarov is an attractive alternative for correction of the cubitus varus deformity. This is one application of Ilizarov we really recommend to every orthopedic surgeon to include in his armamentarium. It is minimally invasive. The best advantage is post-op accurate correction. There is early mobilization, and there is no hassle of hardware removal. Thank you.
Thank you very much, Dr. Rajat. It was an excellent talk. Let's have Dr. Shayan Bari as the next speaker on multi-stage correction of shortening and deformities.
Good afternoon, everyone. I am Dr. Shayan Bari from Dhaka, Bangladesh, and I will be talking about multi-stage correction and shortening and deformities of the lower leg in children and adolescents with the help of Ilizarov technique. It's not working. No, I just not working. Sorry for the technical difficulty. Okay, I've done my graduation from Dhaka, and I have an advanced diploma in Ilizarov technique from Kurgan, and now I'm currently a PhD candidate studying in Tashkent, Uzbekistan. And I practice in Dhaka. We have just spent 25 years of our Bari Ilizarov Orthopedic Center, and I thank all the organizers of Asamicon for arranging this wonderful conference. Now, the deformities. Lower deformities, we know, they include non-unions, they include infection, genuvarum, genuvalgum, procurvatum, and recurvatum deformities, and limb length discrepancies. Sometimes they're often associated with osteomyelitis. Now, limb lengthening, we use follow the Ilizarov methodology of the law of tension stress as put forward by Professor Ilizarov. Corticotomy, we do a low energy corticotomy and with preservation of the periosteum, endosteum, and the bone marrow. And we usually use all wireframe, Ilizarov wireframe. I'll show you a few cases. This was a case, a 4.5-year-old boy with a pathological fracture and chronic osteomyelitis of right femur with discharging sinus. He came to us, we fixed the frame, and we went for the correction of deformity first. And then the second date of operation, he was having LLD of 12.5 centimeter at the age of 16. We went for femoral lengthening and bifocal tibial lengthening. And we lengthened 4 centimeter from the femur and 4 and 4.5, that's 8.5 centimeters from the tibia. And this is at the age of 17 with full correction of his limb length discrepancy. The second case is a 4-year-old female girl. She had stiff non-union with procurvatum and varus deformity. At first, we fixed the frame and we went for the correction of the varus and procurvatum deformity, and we wanted to achieve union. After union, she came to us at the age of 11 with 3 centimeter LLD. We fixed the frame again, a stable fixation, and went for corticotomy of the upper tibia. And this is the final follow-up after 8 months. And this is at the age of 17, after 11 years follow-up, showing full correction of LLD, procurvitum, and varus deformity, and we also achieved union and full consolidation. Third case is a 14-year-old male with post-traumatic genu-valgum deformity with tibia valgus and 10 centimeter of LLD, and he also had skin puckering, very bad skin, bad scar. We put the Ilizarov frame, we did an open wedge osteotomy of the femur, and we did tibial lengthening. And this is, after 3 months, we can see a very good regenerate of both the femur and the tibia. And this is the final follow-up showing full consolidation, correction of LLD, correction of the tibia valgus, and good improvement of the skin condition. And this is my publication on multi-stage correction of shortening and deformities in children with the help of Ilizarov device. Why Ilizarov? I chose Ilizarov because it's minimally invasive. You can articulate it against joints, and multi-stage lengthening can be achieved at the same time. And we allow full weight bearing from the very first POT. And Ilizarov apparatus, it utilizes the full capacity of the bone to achieve bone healing. And you can customize it to correct any residual deformities. The only disadvantage is it's got a greater learning curve, and you have to keep the patient under really meticulous, intelligent follow-up. But apart from that, Ilizarov technique and its methodology is a fantastic tool in correcting multi-stage shortening and deformity of the lower leg in children and adolescents. And these are our patients. We allow full weight bearing and movement. We allow movement from the very first POD. Thank you. Thank you all.
Thank you, Dr. Shayan Bhari, for sticking to the time and its excellent presentation. May I now invite our coordinator, Srinivas Yadkikar, to give his talk on HTO for medial compartment arthritis with the Ilizarov method.
A very good afternoon. I am here for the presentation of medial compartment osteoarthritis treated by high tibial osteotomy by Ilizarov method. As we all know, medial joint pain is a common orthopedic attendance in all the time. Often the patient complains of pain following weight bearing, and the culprit is usually the mechanical axis deviation, which leads to the excessive medial compartment degeneration. So the goal of the treatment is to reduce the knee pain and slow down the degeneration process of the medial compartment. As you all know, it is not an inflammatory condition, therefore mechanical axis correction cures the symptoms. So in a patient with the usual presentation of this medial compartment osteoarthritis is a varus deformity. So in a patient with a genu varum or genu varum deformity with or without arthritis, it can be treated by a high tibial osteotomy. It can be done by a closed method or by dome or a medial open wedge osteotomy. The osteotomy will correct the deformity, but also it will improve the lower limb kinematics. We all know this figure that around 60% of the body force passes through the medial compartment. Therefore, the goal of the treatment is to achieve the 3 to 5 degrees of the mechanical axis valgus so that the mechanical axis passes through or near the Fujisawa point. So the medial compartment osteoarthritis can be treated from conservative line of management till total knee replacement depending upon the severity of the conditions. Here we'll discuss about the osteotomy. The osteotomies, all the osteotomies are time tested. The closed method, the closed type, or dome osteotomy, which are performed above the level of tibial tubercle, they all have a good union potential since they are done in a metaphyseal area with the cancellous bone. However, the closed osteotomy, there is a possibility of over or under correction, and it can lead to a failure of the treatment. The union potential in both the osteotomies is good. However, there are possibilities of alteration in the patellar tendon biomechanics leading to a patella alta or patella baja. The fixation can be from plates to staples to the fixators. And here in this series, we will be presenting the results of high tibial osteotomy, which are done by medial open wedge technique and done at the infratubercle level. So the standard investigations, we all know them. The prognostic factors, lesser is the age, good prognosis. So what are the ideal candidates for doing an HTO? Is an patients between 40 to 60 years of age group having a medial knee pain with a reasonably good range of motion and no lateral or patellofemoral joint arthritis and no subluxation. So in our series, in last 2 years, we did 6 cases of isolated medial compartment osteoarthritis from mild to severe deformities. This is one case with a 49-year-old female presenting with a medial joint pain since last 2 years. This is her having a reasonably good range of motion. I'm sorry, the video is not working. Having a reasonably good range of motion. So we did a progressive all-wire construct, 3-ring construct. And this is a oblique osteotomy can be seen with a small incision. We did a medial open wedge osteotomy. After doing osteotomy, the connections were made by hinges. You can see the small incision. After the latency period of 7 days, the gradual correction of the deformity was started. You can see the progression of deformity correction from left to the right. And the extensive physiotherapy, which is the important part of the rehabilitation regime, it was done. The patients were allowed to do active and passive mobilization and full weight bearing with the help of walker from post-operative day 2 or 3. This is the patient at 2 months doing staircase climbing with a stick. And the post-operative protocol, this active mobilization was started with as per the pain tolerance. The average time for the deformity correction was 15 days. The staircase climbing was permitted with a stick after 1 month, and the fixator removal was done at 3 months on an average time when the X-ray shows at least 3 cortices callus formation. This is her at the end of 6 months, and this is her range of motion, final range of motion at the 6 months. She is able to do independent staircase climbing. And now what are the possible indications are patients with less than 40 years of age group or patients between 60 to 70 years of age group, patients with moderate patellofemoral arthritis, and also there is a posterolateral corner insufficiency. This is a 65-year-old male who is a farmer, typically complaining of, sorry, this again video is not working, with a varus deformity and having typical complaints of difficulty in squatting. So he wanted to go back to the activities, so he was subjected to a similar type of osteotomy, that is infratubercle medial open wedge osteotomy with a gradual stretching of the osteotomy. In this figure you can see as the deformity correction progresses, there is a bit valgus orientation of the lateral hinges, so and the parallelism of the ring is achieved. This is him at 6 months following osteotomy. And this is him after 1 year of osteotomy. Very good. Now this is a bit different case where a patient with post-polio residual paralysis of age 35 years with having a hypertension and diabetes mellitus having a proximal tibia varus non-union. As you can see in this picture, he was having a difficult walk with a hyperextension of the knee and lateral subluxation. So, as the literature suggests, after doing the hypertrophic non-union has the fibrocartilaginous tissue in the hypertrophic non-union has a potential of new bone formation. So these were the preoperative X-rays of the patient, and we did fibular osteotomy of the patient and followed by gradual stretching of the non-union side. This is a progress. And you can see the deformity correction as well as there is a callus appearance. And after 2 months, the varus corrected, the stick, lateral subluxation and hyperextension lost. And this is union at 5 months and final outcome of the patient. This is the final range of motion at the end of 6 months, and the limb was protected for some time with the plaster cast. So the absolute contraindications are tricompartmental osteoarthritis, infective and inflammatory arthritis. So what are the advantages of Ilizarov? Its gradual deformity correction is possible. It is a three-dimensionally stable construct permitting early mobilization. It's a versatile, minimally invasive. It can manage both mild to moderate and severe deformities. The osteotomy below the tibial tuberosity can stretch and retension the medial and lateral structures. Overcorrection of the deformity is also possible, which minimizes the chances of recurrence. There is no retained implant, no future TKR is possible, and no loss of bone stock. Rather, there is a good regeneration of the bone. But there are disadvantages, like it's a bulky frame, the lengthy treatment time, and pin tract infection is there. However, a proper patient selection, proper counseling can avoid these problems. So in conclusion, the medial open wedge high tibial osteotomy performed below the level of tibial tuberosity gradually corrects the varus deformity, and tensioning of the lateral structures, knee complex structures is possible with this frame. So Ilizarov shows the promising clinical and radiological outcome. However, the longer follow-up and larger series sample size is required to prove our conclusion. Thank you so much.
Thank you, Professor Srinivas. Thanks very much. Now, may I invite Professor Jijesh TK from Kozhikode to give his talk on deformity around the knee and the role of the Ilizarov. At the end of this, we are going to have one more talk by Professor Michael Schmidt from Germany on lengthening in children as the last talk of this session.
Hello. Respected Chairperson, good afternoon to all. So I will be talking about deformities around the knee and role of Ilizarov. So all of you know, so these are the deformities. You can get angular or rotational or mixed deformity like this, or a multiplanar deformities, etc. So if you look at the evolution of the alignment, so child born with a virus alignment at the age of 1 year, and it turns to neutral at the age of 2 years, and at 3 years it goes to valgus, and at 7 years spontaneous correction occurs. Similarly, torsion changes also occurs, that is tibial and femur both. So fetus medial malleolus is behind lateral malleolus, in adult it becomes 20-degree external rotation. So similarly in femur also occurs, 1 year it is 40-degree, then adult it becomes normal. So during at any of these stages, any arrest occurs, this rotation deformity or a angular deformity can occur. So if you look at the causes, these are the causes, both it can affect the femur or tibia, that is physiologic genu-viral, metabolic bone disease, bone dysplasias, achondroplasia, congenital tibia vira, and asymmetric causes like blondes, trauma, infection, tumor, radiation, and iatrogenic. So similarly, you have the valgus deformity also, and you have various syndromes associated with the valgus deformity. In the clinical assessment, you would ask the history of any nutritional deficiency, renal disease, muscle weakness, gastrointestinal problems, and family history. And we have to check all these status, that is stature of the patient, whether it is associated with the short stature, upper segment, lower segment ratio, then fascias, metaphyseal thickening, hands, nail change, and changes of rickets, proximal muscle weakness, gait abnormalities, and symmetrical involvement, whether it is asymmetrical or symmetrical, and the level of proximal fibula in relation to that of tibia, intercondylar distance, and Q angle. So all these you have to assess before you plan for a deformity corrections. In the investigation, you have to find out any cause by doing the blood investigations, biochemical markers, genetic studies, and X-ray full length, AP lateral, MRI to assess the 5 series and facial mapping, and CT, all this you have to do before you touch the patient. So coming to the management part, the genu-virum first we'll discuss, and you should know before that what is genu-virum complex. That is, if secondary changes associated with the genu-virum, that is internal torsion of the distal tibia, intowing of both feet, tight medial structures, lats, lateral structures, and patella face forward while walking. And similarly, you should know what is aberrant genu-virum. Due to anteversion of the femoral leg, there is a medial rotation of the femur and looks like bow leg. So coming to the treatment options, these are the options available. That is a conservative and growth modulation, epiphysiodesis, osteotomy correction with internal or external methods. It depends on the patient factors. So we'll discuss some cases, and that is physiologic genovarum. This is physiologic genovarum. So usually the treatment is spontaneous regression occurs here, but sometimes you have to do orthosis, and if it is progressing, you have to do the growth modulation, and still it is not correct, and you can do the corrective osteotomy. This girl, 3.5-year-old girl, presented with a progressive deformity of physiologic genovarum. So she was initially treated with the braces and all, and this girl was treated with a 8-plate of growth modulation. So these are the serial X-rays where you can see the alignment is getting corrected. At the age of 7 years, the alignment is corrected, it was removed. Another girl, 8-year-old girl, where you can see say Blount's disease, you can see the X-ray, the epiphyseal and physeal problem, and this case was treated with a staged manner. So first we corrected the epiphyseal elevation, that is hemiplateau elevation, and put a cancerous screws, and corrected the epiphyseal problem first. Then Elizarov was applied, and metaphyseal deformity was corrected. There is an oblique plane deformity was done, oblique plane calculation was done, and it was corrected. Another girl, 13-year-old girl, deformities of both lower limb with severe deformities in multiplane. So it was found to be a renal leakage. She was treating with various places, and finally came to me. And this was the X-rays and clinical picture, and the planning was done. And he would decide to do in 2 stages, first in tibia and then in femur. So the tibial deformity was corrected with Elizarov, initially with the Elizarov hinges, followed by the X support to refine the deformities, because it was a multiplane deformities. Then femoral correction was done with Elizarov hinges. These are the X-rays and clinical picture after the correction. You can see the mechanical axis well aligned to this. And another case, a 16-year-old boy presented with varus knee, and he had a history of surgery for swelling of knee. So there's a deformity developed following the surgery. And you can see these are the X-rays where he has a distal femoral varus and LLD and a flexion contracture. And the deformity was corrected using here mechanical axis planning with the Elizarov, and lengthening was also done. And facial bar resection also in that case. Another girl, 16-year-old girl, presented with bilateral varus deformity. Actually, she had an initial valgus deformity. Somebody has done the valgus deformity to correct that, and it resulted in varus. This is the X-ray, initial valgus to varus. So this girl was corrected with an acute correction with a plate. There was a mechanical axis planning was done here. And here, another girl presented with a deformity like this and severe pain. To find out the reason, we evaluated her, and she had a history of fracture, which was fixed and resulted in a valgus, and corrective osteotomy was done, and which resulted in virus. And we further evaluated to find out the cause of the pain, which was parathyroidadenoma was found, hyperthyroidism was present, and that was excised, and pain was completely relieved. Then we did the deformity planning. She has a distal virus and a distal procuratum deformity of the femur. So here, this anatomical planning was done, and intermittent nailing was, IMSC nailing was done, and a 2-level osteotomy was done, and it was corrected. You can see that the final alignment. And in the second stage, we did a Elizarov lengthening of the other limb, and this is a final X-ray of the right lower limb. So that was all about the genovarum. And genovalgum clinically, you have to assess clinically again, like the genovarum. You have to see the gait. There will be history of easy fatigue due to the swinging of legs, and shoe collapse immediately due to the pronated foot, and calf and leg pain, and patellar malalignment, and obesity due to inactivities. And apart from the angular deformity assessment, you have to assess with intermalleolar distance, lateral tibial femoral angle, Q angle, patellar instability, and tibial torsion, and flat foot. So similar to the genovarum complex, you have genovalgum complex also. That is external rotation deformity of the distal end of the femur and the tibia because of full of tensor fasciae lata and biceps, and internal rotation of the tibia and lateral subluxation of patella, shortening of the lateral structures, and elongation of the medial structures. So the treatment methods again in genovalgus is conservative. We can do the stretching of IT band, shoe modification, knock knee brace, growth modulation, epiphyseal, and corrective osteotomy. So this is one case of genovalgum, physiological genovalgum, and usually this physiological genovalgum spontaneously resolves by the age of 7 years. And this is another case, a 16-year-old girl presented with the right side valgus deformity, as you can see here, the clinical picture and the X-ray. And the mechanical axis planning was done, and the LDFA was the 79, MPT was 92 here. And the option available here is to correct is either you can do the acute correction or a gradual correction. So you can do the internal fixation or an external fixation. These are our anatomical and mechanical access planning. And since she was not willing for an Elizaro surgery, and did it with a intramedullary nailing. So here a single level osteotomy is corrected. Another girl, same 15-year-old with a valgus, and she was treated with these are her X-rays, and LDPA was 71 and MPT was 91. So the deformity was in the distal femur, and this was corrected with a plate. And another girl, valgus deformity, and this is the mechanical access planning. Distal LDFA was 73 and MPT was 85. And this girl was treated with the Elizaro. So all the, this is after the removal of her frame, and all the patients having the same problem, but treated with in different manner. One is with plate, one is with a nail, and other is with Elizaro. So the question is, which is the best implant to do this deformity correction? So you can correct the deformity by any methods, but internal fixation, external fixation, but you have to follow the principle of deformity corrections. If you don't follow the principle, you may end with the genovirus deformity like this. And take-home message is, deformities around the knee can be angular, rotational deformity, or multiplanar deformities. So you can correct the deformity by any methods. And proper clinical evaluation and assessment is needed before treatment decision. Thank you.
Thank you, Dr. Jijes, for a nice lecture. Now I request Michael Smith for lengthening in children.
Good day. Hello. Good day to everybody. Thank you for the invitation and the spontaneous acceptance of my paper. It was a pleasure to be in India, nice people and wonderful parties. So I will give a very short overview of our treatment indications in limb lengthening and deformity correction in children. The treatment of limb lengthening and correction of axial deviations using a special external hinge distractor system was already introduced yesterday by Ghassan Salmeh. Since 1995, we use this method in 200 children with different indication in the lower limb. They presented with limb length discrepancy and axial deviation. The external fixation system is an arc hinge system, consists of arch with varied diameters, assembled of different sizes of the limb, allows multiplane, multi-directional correction, makes the fixation more suitable to the patient, give more comfort and give a better compliance of the patient. It's easy to control and complications are very rare, mostly superficial pin infections. Yesterday we saw those principles. See, there are half rings with different hinges, and the diameter can be adapted to the patient. Here's one case, 12-year-old girl with achondroplasia. We heard this indication already. We use bilateral surgical and had a lengthening of 50 centimeter and correction of varus deformity same time. Knee function and foot alignment is very well. You can see full weight bearing on the right side. It's another case of a shortening of the right leg, fibular hemimelia, with use of our devices and with simultaneous correction of the ankle joint, and we remove this fibular residuum and full weight bearing immediately. And at the end we had of equal limb length. Another case, 13-year-old girl with achondroplasia. Another case with tibia hemimelia. We start the surgery at the age of 3 years, and yet several surgeries. This is during, we use the tibia, the fibula for the tibia, and had full length at the end of the treatment, and also correct the ankle joint. Another case, congenital shortness of the right femur, 8 centimeter, varus deformity, a 6-year-old girl. We apply the fixator on the right femur. You can see during the treatment, full weight bearing. And another case, a 4-year-old boy with a severe femur deficiency, starting the treatment at the age of 6. First, we fix the hip joint, we distract the hip, and later apply a fixator on the right femur, lengthening of 14 centimeter. The boy then came to Germany as a refugee. We continue the treatment. In Germany, we did another lengthening of the right tibia because we couldn't lengthen the femur anymore. And at the end, we had full length. And this is a patient in my office during the treatment. And this is a picture during the treatment. We also fix the ankle joint and correct the leg and the ankle at the same time. In conclusion, this external fixation system is comfortable to the patient. It takes the shape of the extremity. It allows free movement of the nearby joint because of using of different size of the arcs, easy to correct in all axial and rotational deformities. In addition to lengthening, we use special hinges, suitable fixation because we insert the wires and the screws in a position where it's less painful, and we try not to insert it through the muscle. It's easy for the surgeon to handle, and easy X-ray control during and after the surgery, and it's very high acceptance of the patient. Thank you very much.
Thank you, Dr. Smith. I think I request all the speakers of this session, please come to the dais. No time. Only gift. Okay. Presentation of momentum.
I'll invite Dr. Das sir to please give the memento to Dr. Nora Linda, please. Please. Dr. Nora Linda, please. Dr. Nora Linda, please. Dr. Nora Linda. Dr. Urta Kulkarni, madam. Dr. Mokavigao, please. Please, sorry. Okay, doctor, please. Yeah, sorry, serious. Yes. Okay. Dr. Shayan Bari. Dr. Jijesh. Dr. Jijesh Kumar. Rajat sir. Rajat sir. Yeah. Dr. Jain Sharma sir. Yes. Dr. Jain Sharma sir and Dr. Priti Singh sir. Please. Yes, sir. Last. And Dr. Vikas Gupta. जैन सर को हो गया? Can we take a group photo, please? Thank you so much, everyone, for this wonderful session. Thank you so much.